Hi, everyone. Good morning, good afternoon, and good evening, wherever you are. We are all welcome to today's session. I think we had a very interesting session yesterday, and we really look forward to even better sessions today. Before we get started, please feel free.
All right, this is Marilyn Butler. It looks like Professor Emmanuel Amle's connection may have disappeared for a moment. And he was in the process of welcoming everyone and encouraging everybody to use the chat to enter any kind of questions for the speakers, because we'll be monitoring the chat and sending some of those questions to the moderators. So everyone should mute except for the moderators, and I think we can begin the sessions now. So Milind, go ahead and you can introduce yourself.
Hello, I'm Milind Chitnis. I'm a pediatric surgeon in East London in South Africa. And my colleague today is Dr. Peter Kaima. He is a pediatric surgical fellow in Kampala, Uganda. So welcome to you all. And I just need to find out my program. Yes, I think today we have talks on selected areas of research and member projects. So I think I invite the first speaker. It's DCP4 and children's surgery, 8,000 days. So I think the first speaker is John Bundy. So John, you can go ahead.
There's no sound.
Sorry, Ruth, we can't hear anything.
Hi, Milind, this is a record. I was asked to record it, so you've got the recorded message.
Yes. I'm just going to write it.
Ruth, I think we just started to hear the audio, so why don't you just go back to the beginning and start it over again? I don't hear the audio now.
I think let's start from the beginning.
Hello there, my name is Donald Bundy. I'm from the London School of Hygiene and Tropical Medicine. I'm presenting today with my colleague Tina Sei-Olajide on the topic of the first 8,000 days of life and the role of pediatric surgery in that. So the two presentations, mine is first going to focus on why is that a crucial period for achieving our potential as humans. And then Tina is going to talk about the pediatric surgical perception of that same period of time. So let's start with thinking about this first 8,000 days. What is it we're talking about there? That's the period from birth through to the early 20s, the period during which a human being grows up and becomes an adult and really establishes themselves for the rest of their lives. So that's a vitally important early part of life. It's when we are educated, it's when we grow. And here I've got a slide that shows 3 dimensions of this. All of these are on the same x-axis from 0 through to 20 years of age. The top one is looking at growth in height, and the bottom 2 are looking at brain development. And if we just focus on the height curve at the top, we can see at the far left the first 1,000 days and the dramatic increase in body length that we see during that first 1,000 days. Well, that's where we grow at our fastest. But we can also see that throughout the 20 years, that there is continual growth, actually substantial growth throughout most of that time, declining at the end. And then around puberty, we see these dramatic peaks in both girls and boys at different times, dramatic peaks in height gain, in often reaching the same rates of growth as were last seen when we were 2 years of age. But now we're gaining 50% of our adult biomass in that short period of time. So dramatic change. First 1,000 days, yes, but it's not stopping during the period thereafter. And with the example of brain development, the 2 slides below, it shows how brains too continue to develop throughout this period. Indeed, there's a really accelerated brain development that happens towards the end of adolescence. So a crucial period, a dynamic process over these 8,000 days. First 1,000 days crucial for initial development, for laying the foundations, but the next 7,000 days matter too. And this is the key point, that we now talk about 8,000 days as a paradigm. That if we look at the life course, the first 1,000 days are essential: maternal, intrauterine, infant, neonatal development in those 1,000 days. But then in the next 7,000 days that takes us up to the beginning of adulthood, there's also a dynamic process. We need to sustain the gains that were made in the first 1,000 days, and then also have support during vulnerable phases and vulnerable situations during the next 7,000 days. And as Tina will talk about in terms of pediatric surgery, there are huge roles here. The correction of congenital anomalies to prevent lifelong disability and to promote the quality of life, and the proper care for adolescent pregnancy, particularly young adolescent pregnancies, which may well require surgical intervention. So how we are, and this is the key point, how we are at the end of that 8,000 days determines our whole subsequent achievements in life to a very large extent. And this is best illustrated by this concept of human capital. So this is not economic capital, but it's the human capital of a country, the sum of the population's health, skills, knowledge, experience that makes up the population of a country. And it raises the question, and these are data from the World Bank, it raises the question about the human capital index. How well is the population able to contribute to the nation? If we look at the graph on the right, here we've got human capital index versus GDP per capita, so the income of countries. And on the right, the high income countries, we can see that some 70 to 80% of the wealth of nations at that high end is directly attributable to their human capital, to their people. But at the other end, if we go down to the left of the curve, where we're seeing countries with low GDPs, then we can see that about 30% of the wealth of the nation is coming from its population, a dramatic difference. And at that poor end, the resource poor end, there's a double tragedy here, because it means that individuals are not achieving their full potential in those 8,000 days, but it also means that the society as a whole is undervaluing its human population. And we hope to make the case then that surgery, pediatric surgery during those 8,000 days is an important part of the promoting and developing human capital in a nation. And these concepts were developed by the Disease Control Priorities Project of the World Bank, an analysis, a publication that started in 1993 and is a major source of information for ministries of finance or to determine where to invest. And in edition 3 of Disease Control Priorities, DCP 3, this issue of 8,000 days was highlighted. The need to focus, yes, on the first 1,000 days, but also to invest in the next 7,000 days. And in DCP 3, there was also a very specific focus on the issue of surgery generally, surgery in low-income countries, the importance of that, the affordability, the desirability of that. And what we want to do as we think towards edition 4 is think about the specific role of pediatric surgery in these 8,000 days. So bringing together the surgery issue and the 8,000 days issues together. And that's, I hope, what we're going to discuss over the course of this session. The world has changed dramatically over the last year or so due to COVID. And one of the remarkable achievements or consequences, shall we say, of COVID is a realization of the importance of those first 8,000 days of life, the importance of educating and raising our children. And this has been realized all over the world. And I'll just give some examples here of heads of state and ministers who've spoken out about this. And I just make a contrast in the president of France, President Macron, President Kagame of Rwanda, different resource bases, but nevertheless making the same point that we need to invest in our children. And we never more did we need to invest in our children. And so these heads of state and leaders created a school meals coalition, as they called it, in just September last year. This was part of the UN Food Systems Summit. Just in September last year, they called it a school meals coalition because meals are the most obvious thing that they would be offered. But this is about health, education, nutrition of children in the 8,000 days. How do countries promote that? And should that include access to surgery too? And these are the countries so far that have since September signed this declaration of commitment to push this idea forward. 67 countries, as I say, resource rich and resource poor. And alongside them, 60 partners, including a joint statement by the head agencies emphasizing this focus around the early years of life. And in creating that coalition, there was also a decision to create a research consortium for school health and nutrition that would seek to provide an independent view so that to support the decision-making of countries. And again, that was launched just in May last year, again with international figures getting behind this and in support of these 67 countries. And the mandate for this research consortium is to promote credible and independent research to inform evidence-based decision-making. And that's exactly where we want to go today in our discussions around pediatric nutrition. What's the evidence? Do we need to generate more evidence, as in the green box? Or are we in a place to provide policymakers with programmatic guidance on how to move forward on that dimension of health during the 8,000 days? And so I want us to move on to try and address these two questions. What would it take to promote global access to pediatric surgery during the next 7,000 days, and the emphasis on global? And secondly, how could GICS and the Research Consortium for School Health and Nutrition work together to make that happen? And I'm going to hand over now to Tina to talk more directly about the pediatric surgical component of that. Thank you very much.
Good day, everyone. I'll be taking the second part of the discourse on surgery and the first 8,000 days of life. As a background, recent attempts to address critical development phases have essentially focused on medical conditions, and the volume 8 of the third edition of Disease Control Priorities, despite its very striking findings, made little mention of children's surgery. So basically, children's surgery has largely been unaddressed in child health policies and child health plans of most countries. And for countries that have developed their national surgical plans, most of which essentially are in low-middle income countries, there has been very little focus on children's surgery, except in Nigeria's plan and now in Pakistan's plan. And even where there is investment, focus is essentially in the first 1,000 days, and beyond there's a little investment focus or emphasis. Concerning disease burden avoidable by children's surgery, overall, it's known that surgical conditions account for up to 30% of the global burden of diseases, and the burden of children's surgical disease is disproportionately higher in low-middle income countries when compared with other regions of the world. And in this region, children make up to about 50% of the population, giving an idea of the enormity of the burden of surgical diseases in children within this region. Surgery has very vital and important role in the management of surgically correctable congenital anomalies, treatment of injuries and burns, infections, cancers, and in child and adolescent reproductive health. Now, looking at congenital anomalies, in 2019, it was reported to be the 5th leading cause of mortality in children under the age of 5 years, accounting for over 25 million disability-adjusted life years worldwide. 2/3 of the burden of disease related to congenital anomalies can actually be averted through surgical care. However, in a report by the World Health Organization where they listed simple and affordable interventions for congenital anomalies, surgical care was completely missing and absent. This underscores the existing neglect of children's surgery and the continued perception that surgery is complex, expensive, and not at all cost-effective, despite preponderance of evidence to the contrary. Now we look at injuries. In 2019, injury mortality in children under 5 years of age, unintentional injuries accounted for more than 21 deaths per 100,000 children under 5 years of age, while transport injuries accounted for more than 6 deaths per 100,000 children under 5 years of age. While in children aged 5 to 14 years, unintentional injuries accounted for more than 7 deaths per 100,000 and transport injuries more than 4 deaths per 100,000. Overall, injuries were the second and fourth leading cause of death within the under 5 and 5 to 14 years age group respectively, with the highest mortality from injuries in children occurring in low-income countries and in low-middle income countries of sub-Saharan Africa. And overall, deaths from injury far outweighs deaths from HIV/AIDS, tuberculosis, and malaria combined, also giving us an idea of the enormity of the problem with injuries. It's also known that road traffic accident kills more children in Africa and Southeast Asia more than anywhere else in the whole world. Concerning oncology, there is noted an increasing incidence of childhood cancers in low-middle income countries, making it essentially now a global child health priority. Surgical interventions continues to play a vital role in diagnosis and definitive treatment of these conditions. There, however, exist regional variations and country-level disparities in incidence and survival, with lower human development index countries having 5-year survival as low as 20%. And as we can see, mortality from childhood cancer in Africa and Southeast Asia far outweighs that in other parts of the world with very low, equally high incidence of the cancers. The poor outcomes in low income countries are related to suboptimal care, scarce essential medicines and technologies, delayed diagnosis, loss of follow-up, and financial burden. Overall, at least 60% of children with cancer will die from their disease in this region. There is very limited data on emergency children's surgery, which is a reflection of the death and paucity of data on surgical conditions in this region. Most common surgical congenital anomalies require emergency surgery within the first few days of life, and complicated intra-abdominal infections account for a huge burden of emergencies in children, especially in low- and middle-income countries. As a result, emergency procedures continue to utilize a considerable portion of healthcare resources, despite little investment in scaling up surgical care in children. And as a result of this, there is high morbidity and mortality from emergency children's surgery within the region due to delayed diagnosis, resource shortfalls, lack of access to surgical expertise, and challenges of pediatric anesthesia. Looking at the reproductive health and focusing basically on adolescent pregnancy, obstetric fistula, and female genital mutilation, within the region, pediatric and gynecological procedures often are delayed, even though they're scheduled as elective procedures, they're often delayed, resulting in significant backlog and a significant impact on quality of life. The benefits from fetal and minimally invasive gynecological procedures are reaped almost exclusively in high-income countries, with very little regions in this part of the world benefiting from it. Annually, adolescent births in low-resource countries are as high as 12 million girls per age 15 to 19 years, and at least 10 million of these births are unintended, with 12.5 million births occurring to girls aged under 16. These girls usually are single, less educated, and nulliparous, with sexual risk-taking behaviors, early sexual debut, unprotected sex, multiple sexual partners, and low contraceptive use. In least development countries, at least 39% of girls marry before they're 18 years of age and 12% before the age of 15. The outcome of this is that is related to the outcome of teenage pregnancy, which results in a perpetual state of ill health and poverty, compromised future educational and career prospects, gender inequality, and gender-based violence. And all of these are also associated with substance use, poor access to contraceptives, insufficient healthcare resources, limited sex education, and issues with delivery and termination of pregnancy, which result in significant surgical complications. Maternal deaths rank second among cause of mortality in 15 to 19-year-old females worldwide, and this has seen minimal improvement since the year 2000. Concerning female genital mutilation, over 4 million girls are affected annually. Complications include excruciating pain, sepsis, hemorrhage, and death. Majority of these female genital mutilations occur in developing countries where there are inadequate surgical delivery systems and a huge unmet surgical disease burden, compromising children that come down with complications from this procedure. Obstetric fistula also is another condition which is very challenging within the region, with more than 2 million women affected and over 100,000 new cases annually. This remains a severe underestimation. The prolonged fecal urinary incontinence resulting from obstetric fistula results in tremendous humiliation for those affected, depression, ostracization, and compromised future childbearing. While successful surgical repair leads to the restoration of dignity and well-being and re-engagement with society, access to fistula surgery remains unacceptably scarce in low-income countries, especially for the young adolescents. Now, concerning anesthesia in children, it's been noted that there are higher perioperative morbidity and mortality for children undergoing surgery and within the region, and this is not unrelated to low density of pediatric anesthesia providers and a lack of access to continuing education, appropriate equipment, infrastructure, and medications to provide safe anesthesia to these children. Comparing the density of physician anesthesia providers in different regions of the world, in high-income countries, there are about 18 per 100,000 physician anesthesia providers, while in low-income countries, as low as 0.19 per 100,000 children. Now, overall, children within the region experience delayed treatment, and this results in chronic disability, with resulting marginalization, disengagement from school, and undue burden on caregivers. There is higher morbidity and mortality. And what this underscores is the urgent need to scale up children's surgical infrastructure and workforce to address the surgical backlog and the unmet need. As I had mentioned earlier on, there is still existing erroneous perception that surgery is prohibitively expensive and complex in low and middle-income countries, and this has remained a substantial barrier to including surgical interventions in global health efforts, although these have continually been refuted by evidence. Defining the economic value of health intervention will continue to remain a powerful advocacy tool and a very strong campaign tool for resource allocation to children's surgery. Despite growing literature on procedure-specific cost-effectiveness analysis for children's surgical procedures, there is need for accurate definition of the cost and value of children's surgical care over a diverse range of countries and healthcare settings to make these findings more generalizable. What needs to be done currently? There is a need to raise more awareness and galvanize more action towards scaling up access and improving the quality of children's surgical care within the region. There's a need for public health advocacy at international policymaking levels. There's a need for advocacy towards policymakers and government and within medical professional communities and to funding agencies. Incorporating children's surgery into existing child health plans and policies, as well as country surgical plans and national strategic health plans and policies, will go a long way into strengthening children's surgical care within the region. GICS remains a major player in scaling up surgical care in the first 8,000 days of life through advocacy and coordination of activities towards cleaning up care, and also through creating guiding documents to support children's surgical policy making and delivery. This has been clearly exemplified in the creation of the OREX document, which was very useful in including children's surgery in Nigeria's surgical plan. Thank you very much.
Thank you, Tina. Peter, are you able to compile questions?
Yes, I we have only just one question from the chat.
Okay.
Thank you. This question is coming from Greg, and is asking, how should low and middle income countries stakeholders continue an investment in children through the first 8,000 play in that continued investment?
And Peter, the question is addressed to?
The question is addressed to Dr. Don.
Don, are you able to answer this?
Yeah, sure. I hope you all can hear me. Thanks for this opportunity, much appreciated. So Greg's question was about how to invest in that period, and I think that's really what Tina was addressing in her presentation. That there are clearly a number of surgical responses where we're simply underperforming globally during the 8,000 days, particularly during the next 7,000 days. And there was a particular focus on correcting congenital anomalies and on surgical support for pregnancy. And I think the overall point here is that the survey that GICS conducted on the data that were presented here are very convincing. And I think we need to make a case for pediatric surgery going forward. So I'm hoping that one of the outcomes of this discussion is that the Research Consortium for School Health and Nutrition and GICS can get together and create a community of practice to try and make a strong case for this area of investment. And can I just say, Peter, I also saw there was a comment from Emily Smith at Duke asking about how to get involved with this. Well, what I'm hoping is that we will be sending out these presentations, and you can use those via the website to get in contact. But I'm also hoping that the surgical team, the children's surgery team, will also be sending out information about this and trying to create a group that would focus specifically on pediatric surgery during the next 7,000 days. I hope that answers the questions.
Okay. Thank you so much. I think that was the only question that is in the chat at the moment.
Okay, thank you. So we will now invite Emily Smith to speak about Houston metrics. We can show the video now, please.
Thank you for having me today. I am Emily Smith. I will present on behalf of myself and Dr. Tamina on our working group that we're doing with the Epstein Financial Risk Protection Metrics. So the fundamental purpose of financial risk protection is to make sure that all people have access to surgical care that they need without experiencing some sort of financial hardship. And this certainly is integral to SDG 3. Specifically, I've highlighted on the screen 3.8 that financial risk protection in healthcare is essential to achieve not only universal health coverage, but making sure that people, again, don't experience a financial hardship due to surgery. As a background, the definition of the financial risk protection indicator relevant to surgical care has certainly been refined over time. The Lancet Commission on Global Surgery highlighted 2 indicators that I'm sure everybody is well aware of: the catastrophic health expenditure and impoverishing expenditure. This chapter focused primarily on protection against catastrophic expenditure from the first Epstein working group. The second Epstein financial protection risk working group recognizes that many individuals who need surgical care aren't able to access it, often for reasons of affordability. As such, a measure of FRP that only counts the individuals who access surgery would inaccurately capture the overall population level impact of FRP. Thus, we have to differentiate, and we chose to focus on the percentage of the population that would be at risk of catastrophic expenditure if surgical care was required. So the purpose of the Epstein 2 working group to help refine the FRP indicator definition even more was to introduce a definition in terms relevant to assessing financial risk protection, and also to provide practical recommendations of how do you measure and evaluate that protection across a variety of contexts and countries. So the overall definition that we use for FRP was defined as the proportion of the population of a country at risk, again, of catastrophic expenditure, if they were to require surgical care, not necessarily if they actually accessed that. So the 3 main data points to calculate the FRP is the numerator, which is the total direct out-of-pocket costs that households will face when and if patients access surgery. The denominator is the total annual household expenditure or income of the family. And then the threshold is at which an expenditure for surgical care is considered catastrophic. And we chose to align the document according to 3 different data sets. And really this is on capacity and also the location of where this would be measured. There's the basic, the intermediate, and the full data set. And the basic and intermediate data sets are pretty much the same. They differ only in terms of the breadth of the surgical cohort. So the full data set differs in 2 bigger ways. The first is that it includes more procedures, and the second is that it has more detailed data collection occurring from both a national and a local level. As a result, you can already tell that the denominator is going to be a bit different for each data set, but we do recommend community-based surveys to be the denominator in all data sets, as they're more inclusive to capture not only people who could access care, but those who would need to access it if surgery was needed. And lastly, for the sake of time, I thought I would just share a little bit more of the nuances between the 3 data sets. Again, they differ in terms of complexity, number of surgery conditions that are captured, and how we capture that data from either a national standpoint or a community standpoint. Thank you for having us today.
Thank you very much, Emily, for presentation. So I think what we want to discuss is to discuss this a little bit further. So I will start with Tina. Tina, I know you've done some work regarding financial risk protection and catastrophic health expenditure as part of your work on the Nigeria's ENSO. Can you share with us a little bit of your thoughts regarding this area?
Thank you very much for this opportunity. From the work that we did during the, while developing the National Surgical Plan, what we found out was that we analyzed retrospectively about 48 children who needed to have surgical intervention for typhoid intestinal perforation. And we found out that all the families were at risk of catastrophic expenditure from the cost of surgery alone. That's without including all the other expenses that they had to make. And practically all of them had to pay out of pocket. So well, the other striking thing we found out was that if this care was done, they received this care at a tertiary health center. But that if this care was received at the district level hospital or the first level hospital, the cost would have been much lower than what they experienced at the tertiary center. So the implication of this is that if surgical care is scaled up at first levels, then there'll be a corresponding decrease in the risk of catastrophic expenditure for those seeking care. So there is a need to scale up surgical care for children at first level hospitals and also develop appropriate referral pathways for this condition so that they can first of all get to the first level hospitals where the care, if scaled up, is available before they get to the tertiary level hospitals where they'll end up having a greater risk of experiencing catastrophic health expenditure. However, ultimately there needs to be development of a sustainable funding mechanism that prevents out-of-pocket payments for children's surgical care. And as it currently stands, even for the very few people up in Nigeria, that's just about 3% of the population have access to health insurance. For that very small percentage, the insurance coverage usually does not address congenital needs in children. And we know that a lot of kids still come in as emergencies with congenital problems. And even those that have elective conditions as well, all these are not covered by the health insurance. So there also needs to be a change in that for us to make some improvements into reducing the risk of catastrophic health expenditure. Thank you very much.
Thank you, Tina, for sharing that your thoughts on that experience. And as Emily indicated in her presentation, so we actually underestimating catastrophic health expenditure because we are looking at only those who have actually assessed care. So I think my question would be to Tamina and Emily. So what can we do in our respective countries and as GICS to really better understand the burden and the extent of CHE for children's surgery across the world, and particularly in LMICs? So maybe Tamina first. If Tamina is Tamina with us? So Emily, if you can give us more insights, what can we really do as GICS so that we can get a hand on really the extent of CHE rather than just measuring for those who actually assess care?
Yeah, that's a great question. I think Tamina is here, and feel free to interrupt me and chime in at any point. What can we do to get the right calculation? And we really wanted to do that with Esteem 2, which you heard me talk about, dealing with who is in that numerator of not only people who could access surgical care, but those who actually needed it. So we designed the metric of how to do that according to those 3 data sets and tried to be as pragmatic as possible. If you have this capacity to measure the full data set, then do that. But if you can only do the basic data set, who needs to be in your numerator and who needs to be in your denominator? So at the end of the STEAM, we're hoping to have some sort of appendix of where that pragmatism comes in, of what do the community surveys look like? How do you measure out-of-pocket expenditures? And how do you measure the income level? So I think to answer your question, we have to go to the community as well as measure at the healthcare systems. So I think hopefully that document will be what we can do next at GICS through a variety of context and through a variety of capacity as well, but always at the community level. Tamina, I don't know if you have anything. Go ahead.
Thank you. So Tamina, do you want to add something?
Emmanuel, Tamina is here, but I'm not sure whether she's able to hear us. Peter, there are at least 2 or 3 important questions if you want to ask them.
Thank you so much. We have a question to Emily Smith, and it's saying catastrophic health expenditures plus access surgery is a huge topic. Thanks, Emily, for the work on this with other colleagues. What is even more difficult is that people go into catastrophic health expenditures and they still have catastrophic outcomes. What are the best models you have seen that diminish the risk of catastrophic health expenditures? And how can GICS and other members of the civil society advance to address such a huge challenge?
Yeah.
We have another, yeah.
Oh, go ahead.
Yes, okay. Another question is from Samad. Community-based data assessments are expensive and logistically challenging. How frequently do you suggest this data can be collected?
Yeah, those are 2 great questions. I'll answer the first one first, of the models to diminish the risk of catastrophic health expenditure. You know, a few years ago, we GICS got a seat at the table to talk about universal health coverage and why it's important to include pediatric surgery specifically within those financial risk protections. So to protect people from out-of-pocket expenditures, I mean, it's multifactorial, but it's not as simple as just protecting them at the household level through, you know, cash transfer programs or something like that. We really need those inclusions at the policy type levels of those universal health coverage protections. And so I think it's really important to be at the table when those decisions are made. The second questions of the community-based assessments being expensive and logistically challenging, yes, for sure. Hopefully the USTIN protection metrics, the pragmatic ways that we've gone on how to collect that data, makes that logistically easier to do. You know, is it an mHealth program? Is it paper copies and surveys? In terms of the frequency of collecting that data, I mean, I think once a year is probably good. The purpose of the bigger data sets for the USTIN financial protection programs is to also use countrywide level data that's at the World Bank and to augment the local level data to really inform a bigger picture. So hopefully we're making it less challenging to do those assessments, especially through mHealth iPhone type or phone applications.
Okay, I think due to shortage
Thank you
of
so
time.
much.
Yes, Peter, thank you. I think, shall we just go ahead due to shortage of time, and we will listen to the next talk, and the next 2 talks are about WHO collaborations and district hospital training update. And the first talk is by Lee Wallace.
Good morning to everybody. This is Lee Wallace. I'm the lead for emergency care at WHO headquarters, and I'm talking to you a little bit about the approach to integrated clinical care and how the operative care bundle fits into. So we sit within the clinical service and systems unit. We're responsible for primary care, emergency and critical care and operative care, both surgical and anesthesia, and also palliative care, the models of care, the packages of care, and referral pathways up and down the system, also within our remit. We frame what we do as the ecosystem. We really need to put the P on there, P-eco, so the primary, emergency, critical and operative care system. And this slide is from a WHO bulletin editorial last year, where we are trying to place longitudinal relationship with primary care at the center of this system and linking it into the community through the. Just briefly, we have two aspects to our IC2, our integrated clinical care bundle. One is we have guidance, updated toolkits, and the other is that we have training materials. So you'll see on this slide from the IMAI, that's a primary care oriented guidance set. We have some basic emergency care and other emergency care tools, critical care, and then of course you'll all know the surgical care at the district hospital. So we are trying to have the toolkits that go with primary and emergency critical and operative care. So we'll be bringing out over the next year or two clinical decision tools. We'll be bringing out patient encounter forms and standardized checklists, data sets. We already have all of these tools for emergency care. We're busy working on them now for critical care and operative care. And we have an international registry for trauma and emergency care, which we're expanding to include modules for primary care and operative care. It's all I'm going to say about the toolkits. Happy to discuss more in the question and answer session later. But moving on to the focus, which will link to the second half of this talk, which is that we're also doing IC2 learning programs. So courses with a focus mainly on Academy. This is our new state-of-the-art learning platform for health workers. It's going to be launched formally with the first bundle of courses very soon. The basic emergency care course is one of that first bundle. We have courses across the whole ecosystem coming online. So the Academy is trying to use state-of-the-art technology to really impact on frontline clinical care and on clinical outcomes. So learners will access the digital platform, and it will be available in all of the 6 official United Nations languages. Once they've registered and entered their basic details, they'll be offered a series of learning programs that are suitable for them, or of course they can find any program that they're looking for. The second part, in addition to the learning, is that they'll be connected to peers, so there'll be a community of learners across the platform. And we want people to do what traditionally, I suppose, was done as lectures on face-to-face courses. We'll do all of that material on the WHO Academy platform with some assessment, some gaming, and learning skills from video and interactive digital platform. But then, of course, that will have to be supplemented by a portable learning lab where the skills can be practiced real-time with hands-on and can be demonstrated to an instructor. And they'll be credentialed along the way with a well-developed certification pathway, which involves professional societies. In terms of operative care, we're looking at primarily first-level hospitals in low and middle-income countries. So this is front-level providers who are providing operative care in that level of hospital. And the learning programs that we're putting online will be part of the surgical care at the district hospital and anesthesia at the district hospital. We'll be covering all aspects of emergency and essential operative care, from management and organisation of services at first level hospitals through to fundamental principles. So the overall course will be organisation of operative care at the first level hospital, fundamentals of operative care, resuscitation, anaesthesia, perioperative management, operative care for injury, obstetrics, and then general surgical procedures. And we have professional society partners in all of those areas, but of course the Global Initiative for Children's Surgery, we're very proud to be working with you around Module 6, the General Surgical Procedures, and I'm sure you'll be talking more about that over the day. Look forward to any questions later, and I'll hand over to my colleague now, Dr. Nima. Thank you.
Good morning, good afternoon, good evening, and greetings from rural Kenya. It is a great pleasure to participate in this webinar and to report back on the most recent WHO GICS collaboration anchored in the update of the Surgical Care at the District Hospital Manual. The Surgical Care at the District Hospital Manual is a key WHO guidance document that was last updated in 2003. Its current update comes at a unique moment when there is rapid digitization of learning and healthcare provision. This current update provides an important opportunity for the addition of pediatric surgical care content. As we all know, close to 2 billion children continue to lack access to pediatric surgical care, particularly in rural and refugee contexts. And there's a tremendous need for pediatric surgical content for those on the front lines with very limited resources and very limited opportunities to train in pediatric surgical care. In terms of the process, there are 4 key phases. First, conceptualizing the scope and content. Second, developing the content, and GICS played a critical role here. Third, digitizing the content, and this will be done by the WHO Academy. Fourth, piloting the content with end users and incorporating their feedback in the final product. We had a meeting back in September. Many of you participated. Many of you provided critical feedback on the best way forward. We discussed the content, which focused on high morbidity and high mortality conditions. We discussed the structure, which included key principles, pitfalls, and real-life cases. I am delighted to report that our collaboration delivered in record time, with 31 consultations and the delivery of 23 modules, including content on common procedures such as hernia repairs and high mortality conditions such as malrotation and volvulus. I would like to take this opportunity to say thank you. Thank you for your participation. Thank you for delivering the content. We could not have done this without you. I look forward to more collaborations, and more importantly, I look forward to more collective action to save the lives of children around the world. Thank you.
Peter, we don't see Nima or Lee in the meeting. So I just wonder whether Emmanuel will be able to answer questions. Are there any questions, Peter?
At the moment, we don't have any questions yet in the chat.
Sorry, Peter, I didn't hear you.
At the moment, we don't have any questions in the chat.
Okay, okay. Then I think it's time to proceed to the next session. Unless Emmanuel, do you want to make any comment?
No, the only comment I have to make is that we are looking forward to the completion of the manual that Nima spoke about, and we hope that in the coming months, it will become available for use, and that should help improve children's surgical care in LMICs. And thanks so much to everyone for contributing.
Thank you, Emmanuel. So I think we can go to the next presentation. about nursing wound care project by Vinitha Ravindran.
Hello everyone. This is Vinitha Ravindran speaking on behalf of GICS Nursing. Greetings from the GICS Nursing Group. I'd like to take you through the wound care project that we have developed over the past 2 years and report to you where we started and where we are now. After our meeting in South Africa in 2020, the nursing group started meeting quite often. In the first year, we wanted to have a focus for GICS nursing as we brainstormed many topics and many issues in pediatric surgical care. The wound care guidelines and the need for clinical wound care guidelines came, especially for the developing countries, came up as a thought, especially from Malawi. And when Ken from Malawi brought this need, the nurses group thought it was a good priority that we can look at, and we started developing thinking in that direction. So we developed some steps. We thought first we need to have a concept note. So towards developing this concept note, the members at that particular time were requested to give a short write-up on pediatric wound care practices in their own countries. And we thought that with the summary of accounts from the country, we will also pull out some of the evidence from the literature, and we'll use both these information to develop a concept note. And this concept note was developed by the end of April 2021. The contribution for the concept note came from individual nurses from 6 countries: Malawi, Nigeria, Ghana, Kenya, India, and USA. The summary of the notes, although was not elaborate or wide, gave vital information on what were the practices that were being carried out in each of these countries. And it gave rich information of some of the indigenous practices in these countries. So the summary of this account really helped in developing the concept note, and along with the literature support, Melanie Stroud helped us to develop and complete this concept note. It was a beautiful concept note that was written up and was appreciated by GICS leadership and members. When we finished developing this concept note, we also recognized the need for knowing the current wound care practices in these countries, especially the developing countries, to know objectively about this information. So we realized that we need to collect information in a much more organized way, for which a survey was needed. So we also realized that the survey will help in gathering data in a very formal way, and we will be able to put together the information and synthesize wound care practices from different countries. So we started developing the form survey, and at this time we had multiple sessions on finalizing the survey. We had meetings with the nursing group as well as the GIG leadership. We had many times had to exchange ideas over emails so that all aspects of the wound care will be included in this survey. Again, we're thankful to Melanie, who spearheaded the formatting of this particular survey. Initially, the survey was for only developing countries. That was the idea that we had. But once we talked to GICS leadership, we realized that it was important to include developed countries also, as it would help us to compare practices from developing countries to developed countries. And it will give us, we thought, it will give us much richer data, which will be much useful in developing guidelines. So the survey was developed and finalized in June 2021. Once we developed the survey, to roll out the survey, we realized that it's important to get ethical clearance so that the survey will go with this clearance, and also it will be easier for us to publish whatever data we get from analyzing, from the analysis, and the findings can be easily published. So therefore, we thought of getting this ethical clearance, and India took up the responsibility. CMC Vellore IRB was thought to be a good place where we can get the clearance. So Vinita, that is me from India, developed the proposal for IRB for the CMC Vellore, and the proposal was submitted to the College of Nursing Research Committee and then forwarded to Institutional Review Board of CMC. The proposal, before being submitted to College of Nursing, it was circulated to all the nursing members who were instrumental in developing the survey. And also it was circulated to the GICS membership, especially to 3 of GICS leadership members who were helping us and guiding us with the survey. After getting input from the nursing group and the leadership, the proposal was submitted to the IRB CMC Vellore India. The CMC Vellore IRB gave many suggestions and corrections, which were again discussed with the nursing group, and then the corrections were incorporated, and the final permission for, or the clearance, ethical clearance, was received in October 2021. So now the survey is being formatted in the Survey Monkey so that it can be rolled out, and we are hoping that it will be rolled out at the end of this month or beginning of next month, and we will be able to gather as much data as possible. And as I said earlier, it will be sent to both developed and developing countries who are members of GICS, and not only nurses, but all the healthcare team members, the doctors, the allied health professionals, and other professionals. Anyone who's involved in wound care in the pediatric surgical unit will be invited to participate. And I hope this will give us rich data to go forward with developing our protocols and clinical guidelines. We hope at the end of this year, we will come up with solid data which we can publish. And also at this time, we are also thinking of publishing the concept note, which we should have done much earlier, but hopefully we'll do it very soon. So at this time, I'd like to acknowledge the contribution from all these members, nursing, and the GICS leadership: Bunmi, Nadine, Melanie, John Mesha, Kennedy, Leah Zami, Mohammed Adamu, and the GICS leadership, Dr. Marlin Butler, Dr. Kokila Lahu, Dr. Risha Madhuri, for their guidance and support. We have had wonderful meetings in nursing for the past 2 years. We have come far. There's so much more to go, and I'm sure we will do it. And I thank Bunmi for her leadership in nursing. Thank you.
Thank you, Vinita. Yeah, we'll go to the next talk. It's by
HPV vaccination to prevent recurrent respiratory papillomatosis, a developing world burden. My name is Shazia Pierre. I'm an associate professor at the University of Cape Town in Cape Town, South Africa, and I am based at Red Cross Children's Hospital. I have no disclosure. So juvenile onset respiratory papillomatosis is the commonest benign neoplasm of the larynx in children, and it's the second commonest cause of hoarseness. It occurs in children under 12 years of age, and it is caused by the human papillomavirus types 6 and 11. They typically present with a triad of symptoms: persistent dysphonia, stridor, which is noisy breathing, and progressive respiratory distress. Now, in South Africa, in the private sector, they just present with hoarseness alone, but in addition to that, in the public sector, they present with stridor and respiratory distress, and some children can present in cor pulmonale due to their upper airway obstruction. These papillomas can occur in the pharynx or the upper oropharyngeal tract. They can spread distally, they can undergo malignant transformation. On the left is a picture of a papilloma on the left cord. On the right is TB of the larynx. Very similar in presentation, different management. This is a child in extremis. Severe tracheal tug, can't lie down, has severe upper airway obstruction. She turns around to look at the anaesthetist, and we subsequently debulked the papilloma. So the clinical course is unpredictable. On the left is a picture of suspension laryngoscopy. On the right, this child has a tracheostomy with a completely obstructed airway. So what are the developing world considerations? Well, children with jaw sometimes present in extremis with an obstructed airway and need surgical intervention. This mirrors all low to middle income countries with their general barriers and social determinants of health. At ENT surgery services in Africa, and we found a shortage in surgical skill set, in equipment, and general health and infrastructure. So it's no surprise that this picture is known by all of us. For sure, we have very poor access to surgical healthcare in Africa and other low and middle income countries. To add insult to injury, the incidence of JORP in the last decade has actually reduced in countries of the developed world where they have access to HPV vaccination programs. We continue to suffer the burden of RRP, and this is mostly in the developing world due to lack of vaccination programs. Prevention is better than cure, and the WHO recommends vaccination in 9 to 13-year-olds before sexual debut, and we recommend Gardasil. Looking at this map of the world, it displays the HPV national immunization programs. This is definitely not developed in Africa and other low and middle income countries. Now look at this map that's overlaying the previous map. The RRP burden of disease globally exists in the very countries that don't have the immunization programs. And this is exactly what we're going to be dealing with for years to come if we don't change this picture. So the barriers to sustainable vaccination programs is really the gaps in disease awareness, competing national health priorities, funding constraints, and provisions of vaccines. Well, the first thing is we need to raise awareness. So we make some noise. And who do we make some noise to? Tell adult ENTs too what's going on. Raise awareness to pediatricians because they're shareholders of child and adolescent health. Let gynecologists know because they are the key holders in HPV advisory boards and can influence the vaccination programs. For governments and Ministry of Health to know that this affects children as well as the healthcare services that surgeons provide. Raise awareness to the World Health Organizations to know that there's a health inequity in the provisions for vaccination programs and provide social justice. To alert the NGOs to provide vaccines and to give due services for surgical interventions where they are not available. Raise awareness through social media to let parents and patients and even doctors raise awareness through advocacy and activism. So a second way is to align our RRP healthcare goals with other HPV-related conditions. Cervical cancer is an international epidemic and it affects the developing world much more. So we need to align our goals to HPV-related conditions such as CA cervix and eliminate HPV-related cervical cancer together with RRP. They require the same vaccination programs also be covered through Gardasil. And the third and final recommendation is affordable and available Gardasil vaccines. It's a global strategy aimed at accelerating the elimination of cervical cancer. This was set up in 2020 and it showed that you can get 90% coverage by the year 2030 for 150 million people. With unconstrained demand scenarios, we may find an elimination, and this is very well a possibility. So vaccine companies, the supply needs to meet the demand, and looking in South Africa alone, one dose of Gardasil is 20 rand cheaper than one dose of Cervarix. And this is a big problem because the national rollout program in South Africa has Cervarix and not Gardasil. So in conclusion, this is a difficult condition to treat. There's currently no cure. There needs to be equity across the globe for HPV vaccination programs. We need to raise awareness for RRP. We need to align our RRP healthcare goals with other HPV-related conditions. And we need to provide affordable and available vaccines. Thank you very much for this opportunity to present.
Hello, thank you very much for this opportunity to present on behalf of the Global PEDSurg Research Collaboration today. We undertook a study on the mortality from gastrointestinal congenital anomalies in low, middle and high income countries globally. This was a multi-center international prospective cohort study. So just starting with some background why we undertook the study. So global mortality in children under 5 has fallen tremendously from 12 million or over 12 million in 1990 to just above 5 million today. However, global neonatal mortality has fallen at a slower rate from just under 5 million to 2.4 million today. In real terms, now almost half of all under 5 deaths occur during the neonatal period. In order to address this, in 2015, there was a publication of the Lancet Newborn series, and every newborn action plans were introduced in LMICs across the globe to try and tackle neonatal mortality. However, surgical care for neonates wasn't mentioned. And when we look at neonates within global surgery, we can see that surgical mortality in LMICs amongst neonates is estimated at around 18 to 42%. This compares to a mortality of 1 to 4% in older children and adults undergoing surgery in LMICs. However, neonates have yet to be a major focus of global surgery efforts either, and so surgical neonates are falling through the cracks. So why is it important? Well, congenital anomalies, which commonly require surgical care, are the 5th leading cause of death in under 5-year-olds globally. They account for at least 1/5 of all neonatal deaths. In real terms, there's over 500,000 annual deaths from congenital anomalies. 97% of these deaths occur in low and middle income countries. And there's an increase in burden, as you can see in the graph here. The number of deaths from congenital anomalies continues to rise, whereas the number of deaths from common infectious diseases continue to fall. So why did we focus on gastrointestinal congenital anomalies? Well, these are a group of conditions that are often fatal without emergency neonatal surgical care within a few hours or days of life. And they likely contribute a large proportion of the neonatal surgical mortality. So we aim to compare the management and outcomes from gastrointestinal congenital anomalies in low, middle and high income countries globally. We collected prospective data on the 7 commonest congenital anomalies affecting the gastrointestinal tract over a 1-month period between October 2018 and April 2019. The primary outcome was all-cause in-hospital mortality, and we undertook multivariable analysis to identify factors associated with mortality. We collected data across the world from just under 4,000 patients, and these are our key findings. So we identified a significant and unacceptable difference in mortality for all of the conditions, with the greatest difference seen in gastroschisis, with a 1% mortality in high income countries compared to a 90% mortality in low income countries. This was followed by esophageal atresia, CDH, and intestinal atresia. So what factors were associated with the higher mortality? Well, country income status was the highest risk. When we look at clinical factors, we can see that sepsis at presentation was associated with a higher mortality, as was having a higher ASA score or being sicker at the time of surgical intervention, not having a surgical safety checklist used, and not having a physician anaesthetist present at the time of intervention. And then during the perioperative period, not having ventilation or parenteral nutrition available when needed. When we look at factors associated with the lower mortality, we can see that receiving parenteral nutrition was associated with a lower risk, as was use of a PICC line or percutaneously inserted central line. So in conclusion, there are unacceptable disparities in mortality from common gastrointestinal congenital anomalies between low, middle and high income countries globally. Sustainable Development Goal 3.2 that aims to end preventable deaths in neonates by 2030 will therefore not be achieved without urgent action to improve timely access to quality neonatal surgical care in low middle income countries. We identified 3 things that can be done to tackle this. We suggest focusing on antenatal diagnosis and delivery at the Paediatric Surgery Centre. This will obviously help reduce the risk of clinical deterioration prior to surgical intervention. In addition, improving the quality of resuscitation and care at the district level with early and safe transfer to the tertiary centre. And then improving perioperative care at the tertiary level with use of a surgical safety checklist and availability of neonatal central IV access, parental nutrition and ventilation when needed. So in terms of what can be done now, this can be considered in terms of local, national and international action. Locally, multidisciplinary teams can get together to discuss and see what can be done to improve neonatal surgical care at their centre. That team can then also organise outreach teaching to referring hospitals to improve the level of care there and early referral. And discussion can be undertaken to either improve or set up referral pathways and improve communication between the paediatric surgery centres and referring facilities. At a national level, those same multidisciplinary teams can approach their local or national Minister of Health to share the need for improved neonatal surgical care facilities. Neonatal surgery should be incorporated into national health plans and NSOPs. There should be increased training numbers for the whole multidisciplinary team. And we've encouraged the collaborative team members to present the results in local newspapers and press to raise awareness in the local population as well. At an international level, neonatal surgical care needs to be better incorporated into WHO guidelines, so it needs to be included in every newborn action plans, in the WHO newborn care guidelines, and more comprehensively into congenital anomaly registries, which currently miss quite a lot of the conditions, including the GI congenital anomalies. Congenital anomalies should be included within national and international population health surveys. We need to raise awareness amongst major global health funders. We need to incorporate neonatal surgery into international organisational activities such as UNICEF. And GICS Congenital Anomalies Working Group are in the perfect position to come up with an action plan to tackle all of these points. Sincerest thank you to everyone who participated and the funders. If you put Global Ped Surge, The Lancet in Google, you'll find the article, which is open access. And thank you for listening.
Thank you. I think there's one more presentation by Naomi about gastroschisis intervention study. So we can run that presentation.
Hello, I'm very sorry that Dr. Bukhari isn't available to present today, and it's a real honour to be able to present our gastroschisis interventional study on behalf of the study teams. This was a pre-post clinical interventional study at 7 tertiary paediatric surgery centres in Ghana, Zambia, Malawi and Tanzania, with the aim of reducing mortality from gastroschisis, which was between 90 and 100% at baseline in the study centres. So collectively, we produced an evidence-based care bundle. This had core components that were standard across the 7 centres and adaptable components to optimise the care bundle to the local setting. So we undertook a systematic review and qualitative study to help inform what went into the care bundle. And then we undertook a local team consensus process to finalise the care bundle for each setting. So what went into the care bundle? Well, there was a district hospital component, which consisted of a care protocol with plastic application onto the bowel at birth instead of gauze, administration of IV fluid and IV antibiotics, keeping the baby warm through modified kangaroo mother care with skin to skin, and then early referral to the tertiary centre. And then at the tertiary hospital, use of protocolized care with early resuscitation, cot-side application of a preformed silo, bowel reduction, and then cot-side sutureless closure. We used an accelerated and early breastfeeding protocol and IV neonatal nutrition where possible, which consisted of amino acids in most centres, and in one centre they used adapted adult peripheral parental nutrition. In terms of outcomes, the multidisciplinary teams were trained at all of the 7 study centres, and faculty from the study centres went out to the main referring hospitals and district health centres to provide outreach simulation training. In total, over 2,000 healthcare professionals were trained. Neonatal surgery referral pathways were established in all places, and this resulted in an increased number of gastroschisis cases being referred during the study. In terms of clinical outcomes, as mentioned, the baseline mortality was 97%. This is in the 2 years prior to the study. And then during the pre-intervention phase, the mortality fell to 80%. This is because some of the interventions were implemented during this phase. And then during the post-intervention phase, the mortality fell further to 65%, which was significant. In real terms, 68 babies survived during the 2-year study period, which compares to just 3 babies who survived with gastroschisis during the 2 years prior to the study. Of course, there were still challenges, so we didn't tackle antenatal diagnosis. That wasn't feasible, so most of the deliveries were still in the districts. Through the outreach teaching, there were lots of improvements in the conditions that the baby arrived in, but there's still much more that could be done. One of the limitations was neonatal transport or ambulance transport, which wasn't always readily available. So there were still often delays in getting the neonate to the tertiary centre, and sepsis was the leading cause of mortality. So in conclusion, we showed that it is possible to significantly reduce mortality from gastroschisis within the existing healthcare systems in sub-Saharan Africa. However, to achieve outcomes comparable with high-income countries, there needs to be more work in terms of health system strengthening to improve access to quality neonatal surgical care across sub-Saharan Africa. Thank you very much to everyone who was involved in the study and to the funders. And you can look at the study protocol and further details through these references. Thank you.
Thank you to Naomi. Peter, have you compiled any questions?
Yes, thank you. We have a question from to Naomi. How do we improve antenatal diagnosis? That's the first question. And then the second question is, how was the IV and nutrition brought to those centers that did not have that available. Okay, I think that's those are the two questions mostly.
Thank you very much, Peter, and thank GICS for this opportunity to share some of the work we've been doing, and thank you to everyone that participated. In terms of the first question, tackling antenatal diagnosis is obviously a huge challenge, and I think one of the beautiful things about GICS is our multidisciplinary team nature, and I think one of the things we can do within the Congenital Anomalies Working Group is focus on reaching out to collaborate as much as possible with obstetric teams and ultrasonography teams across the world, and discuss together how to try and tackle this to improve training, particularly in the rural regions where it's particularly difficult to access congenital anomaly screening. There's a PhD student that I've been working with recently who's done quite a lot of work looking at antenatal diagnosis of congenital anomalies and LMICs. And some of the research that she's seen highlights that a lot of, I mean, the majority of women are actually having an antenatal scan, but it doesn't include the congenital anomaly screening. So hopefully we can work together within GICS and the multidisciplinary team to think about how to improve training, but also regulation of this service provision, because a lot of the service also happens in the private sector. So that I think that would be important at a policy and government level to think about regulation. In terms of the second question around IV nutrition, so in the study, 5 of the centres use 10% dextrose with locally available amino acids, so either astamine 3 or celamine 10 plus. They're available, and for neonates they cost approximately $1 a day in terms of cost across the countries. It was quite standard, and the amino acid was simply mixed into the maintenance fluids for the baby. And with the 10% dextrose and the amino acids, that was calculated to provide about 2/3 of the baby's nutritional requirements, which of course is not the full parental nutrition that we would ideally use, but it's something that's better than 1/3 of the nutritional requirements, which is provided by 10% dextrose alone. And we saw that it was often enough to keep the baby going for the 1 to 2 weeks until breastfeeding could be established. In Muhimbili National Hospital in Tanzania, they were actually able to source and adapt adult parental nutrition to use for neonates, and that cost about $10 a day, so it was slightly more expensive. But they sort of established that resource across the neonatal unit so that families could share bags and that there was less wastage. And I think that helped in terms of the cost.
Yeah. Thank you so much. There's another question. Have you done any outreach with WHO to include in their guidelines to address such a challenge?
Sorry, I didn't quite catch the whole question. Something along the lines of outreach, sorry.
Yes, I think it's mostly a comment, but have you, it's mostly asking if you've done any collaboration with WHO in their guidelines to see how we can improve this care of the gastroschisis patients.
Oh, fantastic. Thank you for that question. Well, obviously, it's wonderful to have heard from Nema Kaseji earlier that she's obviously done a lot of work on the surgical care and district hospital package, which included gastroschisis. And I know that Professor Tamina Banu has been working with the WHO looking at the congenital anomaly registry. But as far as I'm aware, there hasn't been a sort of comprehensive look at including gastroschisis and other GI congenital anomalies into like the Every Newborn Action Plans, and there's the neonatal guidelines from the WHO, which has a sort of section on sort of emergency neonatal conditions, but doesn't really focus at all on congenital anomalies or any surgical care interventions. And I think it would be useful to work with the WHO on sort of updating those guidelines, as well as NEMA and the GICS team has done on the surgical care guidelines.
Thank you, Naomi.
Thank you.
I think we are running just over 20 minutes late, so there are lots of questions in the chat box. I just suggest that these discussions can continue later. So thank you to all the presenters, and I hand over, thank you, Peter. I hand over back to Marilyn.
Good day, everyone. I'll just very briefly be giving an overview of a recent survey that we carried out as a means of fostering equity in global surgery and global surgery collaborations. Okay, so as a background to this survey, it's been noted there are long-standing inequities between low and middle-income countries and high-income countries, that's between global north and south, across all aspects of healthcare. And this has prompted global health and global surgery communities to dialogue to mutually and constructively address these inequities. Now, stemming from these conversations and realizations of the burden of these inequities existing within the global surgery space, a loose coalition of like minds in global surgery came together and formed a transformational dialogue group, which is a group that's comprised of stakeholders and practitioners within of global surgery from high and low and middle income countries across specialties. And the individuals basically came together to brainstorm and discuss these inequities and try and find solutions, to these inequities that exist, and how to go against the barriers to, taking down the inequities. There was, however, a quick realization that more in-depth understanding was needed to facilitate the dialogue and to facilitate the development of implementable solutions. So to better understand the enabling factors for neocolonialism, how neocolonialism manifests, and the experiences of people who have been exposed to neocolonialism, a survey was designed to capture information and data regarding inequities in global surgery, addressing different areas, including clinical practice, research, publications, and basically all aspects of global surgery. The components of the survey were specific questions addressing the different areas where these inequities could manifest themselves in the practice of global surgery and the delivery of global surgery as well, of surgery. And there were also one-on-one interviews scheduled to take place after the web-based survey. And the participants were basically global stakeholders across high and middle-income countries. The web-based survey has been concluded and this has currently been analyzed, while the interviews are ongoing and will very shortly be rounded up. We expect that from this survey, there will be better understanding of the issues involved in inequities in global health and global surgery, and that we will be able to create and implement sustainable solutions to addressing the problems. And we hope that in the coming weeks and months, we'll be able to implement solutions that will mitigate existing inequities in global health and in global surgery. Thank you very much.
Risha, are you taking questions?
Yeah. I don't know whether there are any questions in the chat box, but I just wondered, Justine, whether you could share some preliminary results to suggest what these inequities are and what solutions were suggested. At least a few, since you must be knowing while you're analyzing what the suggestions were.
Thank you very much, Risha, for the questions. From our initial preliminary results, we have noted by comparing the responses from the low and middle income countries and the high income countries. I think it's important to mention at this point that one of the things we realized is that most of the things that happened that within the global surgery space that represented neocolonialism were not intentionally carried out. So there were actions that were carried out in with a motive to help, with good intentions, but then they were eventually seen to be neocolonialistic. Now, part of the problems we had seen included problems in issues during collaborations, issues in differential compensations for use of time, issues with authorship in research, and issues with actually building research capacity during research collaborations, and also during missions where local surgical systems are actually put at risk or weakened by visits from surgical missions. So that's part of the initial problems that we have noted from our initial analysis. And part of the solutions that have been preferred so far from what we have seen include making the collaborations more equitable, having equitable compensations for time, having actual involvement of low and middle income countries in conceptualizing research and also in the implementation of the research and not just in data collection. And then there are also suggestions about actually ensuring that the quality and the capacity of surgical providers coming into low and middle income countries actually is up to standard, and not just trainees coming in to low and middle income countries to acquire skills from the patients in low and middle income countries. So these are some of the preliminary results that we have seen. Our analysis is still ongoing and the interviews are still ongoing with more interesting findings within them. Thank you very much.
Thank you, Tina.
Our next session is a panel discussion on global surgery fellowships, which has emerged from the high-income countries. And we have 4 panelists, 2 from the high-income countries and 2 from the low to middle-income countries, discussing the concept of a global surgery fellowship. So could the 4 panelists switch on their videos and unmute themselves? So we have Alize, Sukriti, Gabriela, and Naomi. If you could just introduce yourselves and get started.
Sure, absolutely. Thank you so much, Prof. Lakou, and thank you so much for the kind invitation. My name is Alize Abbas, and I went to medical school at Dal Khan University in Pakistan, and I am passionate about global surgery. That's what I'm working in, as well as health services research.
Naomi?
Hello, I'm Naomi Wright. I'm a paediatric surgery registrar. I'm currently based in Oxford with Professor Lakou, and I did a lot of my research when I was based at King Centre for Global Health and Health Partnerships in London.
Gabriela?
Hi, my name is Gabriela, and I'm a general surgery medical officer at Chris Hani Baragwanath Hospital in Johannesburg with a special interest in pediatric surgery, and I was fortunate to work with Naomi on global ped surge. I'm also a PhD candidate at the University of the Witwatersrand, looking at indicators of access, capacity, and quality of SAO care in South Africa.
Thank you. And Sukriti?
Hello, everyone. My name is Sukriti Bansal. I am currently a general surgery resident at the Baylor College of Medicine in Houston and part of the global surgery specific track here. Thank you for having me.
All right, so I think you should start your discussion, please.
So, so I can begin and just give a brief overview of some of the things that we were hoping to share with all of you. In the beginning, we were hoping to talk a little bit about, Dr. Bansal will talk a little bit about her experiences as a global surgery fellow at the Baylor College of Medicine, where she's a general surgery resident. And then follow with that, I will share some experiences of my work in global surgery and give a more specific point of view of what medical students and medical graduates, specifically from LMICs, are looking for in such fellowships and what we can do to increase these opportunities. Follow with that, Dr. Wright will talk about some of the experiences from the UK, particularly a proposed global pediatric surgery fellowship. And then Dr. Hemman will talk about her experiences from South Africa. So Dr. Vinsal, the floor is yours.
Yes, thank you. So as I mentioned, I am currently a resident in the general surgery program at Baylor College of Medicine in the global surgery track, which for us, it incorporates a global surgery fellowship within our residency training. So it's part of, we have the match system in the US for when you choose a surgical specialty. And you match specifically into this position, knowing that you have an interest in a career in global surgery. So our fellowship is integrated. It's 2 years. The first year happens midway through training, with your last year coming at the end of training, meaning that you are a board certified general surgeon at that point. And besides the clinical aspects, the program also incorporates a curriculum, which was a large focus of my first year of global surgery training, that is focused on not only the technical aspects of being a surgeon in a limited resource setting, but on also some of the non-clinical skills that are quite essential, including capacity building, research, ethics, and collaborations and partnership. So I think it's a unique program. It is it is a fairly early young program here, and it's obviously based in a high income country, meaning that our perspective may perhaps be a little bit different than our LMIC partners, which my understanding, Prof. Lacroix, is that is the focus of this talk. And I think it puts us in it's a complex question, and it puts you in a complex position, because a lot of us come in wanting to be partners, wanting to be collaborators, and it involves a lot of discussion and open communication in order to figure out the best roles and best ways to come forward with these detailed plans and how we can work together and help.
Thanks, Sukriti. Who's following?
I will go next. So definitely what Dr. Bansal shared is a very important point about opportunities for residents to become involved. But then also when I was in medical school, that's when I discovered that global surgery that I'm passionate about, and I was looking for opportunities to become involved. But I do realize that there are limited opportunities, especially in LMICs, for a dedicated global surgery fellowship for students to do during medical school. So then I decided to do a full-time research fellowship once I graduated medical school at the Global Health Directorate Indus Health Network. And I think that time was really crucial in helping me understand a lot of the challenges that these patients face, because not only did we do research that was looking at outcomes and access to care, I also had the opportunity and the privilege really to work on some of the more things that were based within the hospital and community, looking at how we can improve quality improvement. So the Indus Health Network has an electronic database for all patient medical records, which is not very common in countries like Pakistan. So it was very interesting to see how we collected this data and what were some of the challenges, like the data was missing at times, or they were not, we did not have a standardized way that this data was collected. But this helped us look at some of those things and recommend what we can do to make these things better. But in addition to that, recently there have been studies that have looked at, for example, there was a large study led by students from Incision, which looked at that so many of the students, more than 60%, thought that global surgery exposure is important, whereas only 17% of them really had any exposure. And so I think there are a couple of things that come into play with this, that students may not be aware of what opportunities there are, or there may not be enough opportunities available. But in the face of this challenge, one of the things that's helpful is for faculty mentors who are already working in the field to share such opportunities for students to become available. And I think Dr. Wright and Global Ped Surg have done a fantastic job in that, where so many of the trainees and students from LMIC countries were also able to participate in this, as well as build their research skills through a lot of these capacity building sessions. And then in addition to that, the second thing, which is sometimes a challenge for students to become involved, that we saw as well in my experience, was funding and the sometimes limited availability of that to be able to pursue some of the projects. For example, if you want to do qualitative research, you need access to that specific software that will do that. And then we were very fortunate to be able to get exposure to all of those things. But one other solution to this could be financial and geographical barriers. Is now, because of the COVID pandemic, a lot of these things are online. And so I know that there's some of these fellowships, for example, the Center for Health Equity, Surgery and Anesthesia, the UCSF, they've recently started their fellowships. And my understanding is that is open to students or graduates from any part of the world. And there's also an option to work remotely. So those things which really take away barriers, which are financial, geographical, mostly for medical students, would be very helpful in moving forward. And then the last thing I would just say is that our experience has shown us that medical students and trainees, the earlier exposure they get, the better it is, so that they have an idea of what are the deficiencies that exist in the system where they're going to be caring for patients. And so I do feel that I'm better equipped to take care of patients because of these experiences that I had once I graduated medical school.
Thank you, Elisa. Who's next?
I'm next. Thank you so much.
Thanks,
so similar to Dr. Abbas and what Dr. Hyman's going to share soon, sort of the collaborative research and work that I've had the opportunity to do has really been sort of bespoke and making it up as you go along, applying for different generic fellowship and funding opportunities. So I'm just going to touch on a more sort of formal global pediatric surgery fellowship that's sort of under discussion to happen in the UK. And I've sort of liaised with quite a few pediatric surgery trainees in the UK to sort of get their opinion on it as well. So just sort of to give a background of what it might look like, the proposed sort of suggestion is that it be a one-year fellowship that senior pediatric surgery trainees in the UK could apply for. It would be based at an institution that's already got a long-term partnership with an LMIC institution. So obviously long-term established partnership already in place. It would involve a project that is focused on capacity building or health system strengthening, where the HIC trainee would work alongside and under the supervision of an LMIC supervisor as well as an HIC supervisor. The aim would be to spend at least 3 months in the LMIC setting and to undertake a project together. It hasn't been further established yet. So this discussion is really topical and important to help sort of establish that fellowship if it is to go ahead, to make it most useful for everyone involved, I think. So when I was thinking about who would benefit from that partnership and how would it be best done, so when speaking to colleagues in the UK, they said, well, it's an important opportunity to build lasting long-term relationships with partners in LMICs, and to become part of already established long-term partnerships rather than the sort of short-term mission work. And then they felt that it was important to have a sort of curriculum and talk component so that those that are interested in global health and global surgery can learn, about the ethical components of it and how to best undertake sort of capacity building alongside research. So sort of to get the best out of a sort of learning opportunity. Some were concerned that 1 year might not be long enough to come out with a meaningful body of work. So one thing that we considered was if candidates apply at least a year in advance, then they could have a year to plan the project with the LMIC partners and gain ethical approval together before actually doing the 1 year fellowship, so that then there would be sort of a longer time to complete the work. And then obviously there would be maybe a period of time afterwards to continue that work. Sorry, over to Dr. Hyman.
Thanks, Naomi. Gabriela?
Thanks, Dr. Wright, and thank you for having me to participate in this meeting and discussion. I'll be focusing a bit today on creativity and sensitivities or responsibilities around these new global surgery fellowships or programs by reflecting on my own experience. So my research in South Africa is funded through a generic grant, and it's a scholarship made available through the South African Medical Research Council, and their goal is to train young clinician scientists. And well, through collaborating with various centers in HICs and LMICs and through the mentorship of various individuals, I've come to realize that a lot of the work that I'm doing for, with the Wits Static Regional Collaboration Center or the local Department of Health is really in the role of a global surgery fellow, even though I'm not occupying a named fellowship position. And this may be the kind of flexibility or creativity required to keep our objectives for training fellows, and particularly in LMICs, to keep that objective fruitful, is this kind of flexibility with funding and allocation of funding. And I guess while the fellowships are named, and this is largely because there's a lack of resources for clinician scientists in general in our context, and there are even less funding opportunities for SAO care because we're competing with other priority programs, particularly infectious diseases and diseases of lifestyle in our context. And what this means is I've really had to be creative in applying for this sort of ongoing funding or signing funding opportunities to facilitate SAO work and seeing how we can have a less siloed approach to SAO care. And I think that might be an important aspect of a global surgery or global health fellowship curriculum, is this, I guess, broad perspective. And I guess in terms of, the HRC funding opportunities that Dr. Wright has touched on, and the ones that are currently available, the ones that are being formulated, I think a lot of these opportunities are focused on facilitating studying abroad, or at the moment they're more available for postdoc work, perhaps. And I guess that's a bit different than supporting local training and local conceptualization of curricula. And I think it's an extremely valuable opportunity, and it's an important thing to learn, what areas or what the global north and global south do well, and to be, I guess, mutualistic in this experience. I think there is a lot of value in upscaling local capacity. And I guess that's a challenge or something that should be focused on in the next step. And that's something that would make these global fellowships really robust and ethically responsible, to have some kind of hybrid model where the host, I suppose, is occupying a leadership position in conceptualizing and approaching this fellowship. And I think we're familiar with this idea of recolonizing global health when we think of surgical missions, and it's a bit different when we think about surgical research. And we have to, I think, move beyond just looking at what the value of the data has in implementation and improving access and quality of care, but looking at how the research itself and the training of researchers has a role in strengthening local capacity and care for patients. And perhaps that should be a core component of any global health curriculum moving forward, is that it's not just about the data or the research, but it's also about the researcher and the institution. And I think what Dr. Wright and the Global PSurg project did really well was that they were able to use mentorship and establish or strengthen research centers, both in a clinical and research capacity, to upscale surgical care, particularly for neonates. So my task was to round up our four different perspectives. And I think in summary, what we've, brought up is some things to consider is what currently exists in a developed or well-resourced context, how we access existing resources, how we can be creative and inclusive in establishing new opportunities and pioneer the way forward. And I think at the core, or the common thread, is this idea of being ethically responsible in moving forward with any global health research. So thank you for hosting us today, and we look forward to engaging with the group.
Thanks, Gabriela. I mean, I came up with the idea of having people talk about this because I wanted to clarify that this is not a backdoor for high-income country trainees to benefit from what is happening in the low and middle-income countries. And it's quite clear from the four of your discussions that this is a collaborative way, yet there's a little bit of slant towards HRC with the funding availability. But you as trainees see this as a collaborative process of global surgery fellowships. And I think there's something in the chat that the Royal College of Surgeons of Edinburgh are offering these to LMICs as well. So I'm very pleased to hear that we are going in the right direction with these fellowships. I think we just hit the right timing, and I think there's going to be a 5-minute break to the top of the hour. Is that correct, Madeline?
Yes, we'll take a 5-minute break, well, 4-minute break now, and we'll return and begin the next session at the top of the hour with our NGO updates. So we'll be back soon.
Thank you to the 4 speakers.
Thank you.
Thank you.
Okay, welcome back, everyone. Ruth, could you go ahead and start the next session? Simone will introduce herself and her trainee moderator.
Hello, everyone. It's a pleasure to be here with you. We all know of the importance of the NGOs within our work, and this has been highlighted throughout this meeting. And so I have the pleasure to co-chair this session with Sagar Tontata Nahal. And I think that without further ado, we are looking forward to hear the updates on the NGOs by the speakers. I hope you enjoy it.
Hello, my name is David Cunningham and I'm the Chief Executive of GICS Operating Room, one of the world's leading providers of access to safe surgery for children in low and middle income countries. I have been tasked with doing two things today. Firstly, giving an update on our work providing access to safe surgery, but then, and far more importantly, introducing the next speaker. Please bear with me as I quickly do the former, as I know the latter is far more interesting. However, as a quick update, each year some 30,000 children now have safe operations in one of our 50 operating rooms across 22 different countries. I'd like to express at this point my sincere thanks to our partners at Smile Train, with whom we have forged a formidable partnership, creating capacity for safe surgery and new training opportunities at a rate I do not believe has been seen before in Africa. And our growing database on the outcomes of that surgery provide absolute clarity that the skills exist across low-resource settings to provide world-leading care. What is often missing is the right tools to do the job. We are therefore extremely proud to be the people helping put the right tools in the incredible hands of our partner surgeons. And so together, partners at every level, we proudly save lives, avert disability, and bring hope and opportunity to thousands of children every year. However, the last 2 years have, of course, brought their own challenges. I'm pleased to say that at GICS Operating Room, our model of investing in local surgical teams, strengthening the local healthcare system, and not engaging in mission-based work has allowed us to grow significantly during the pandemic. We were active in COVID-related work too, supporting the delivery of hundreds of oxygen concentrators, ventilators, and some 25 million items of high-quality PPE to the public health services in Zambia, Malawi, Rwanda, Uganda, Mozambique, Botswana, Zimbabwe, Sierra Leone, and Senegal. In fact, GICS Operating Room supplied enough high-quality, brand-new PPE in some of these countries to ensure every single government-employed health worker had access to safe PPE for at least 3 months. Anyway, I could go on about our COVID response work for some time, and I could definitely talk about scaling up access to safe surgery all day. Instead, I'd like to turn to the second of my tasks today and focus on Afghanistan, or to be more specific, on the most incredible, smart, determined, and courageous doctor I have ever had the pleasure to encounter. Dr. Donya Magyo first came to my attention when we were asked if we could help her and her family escape from Afghanistan as it fell to the Taliban last year. What followed, I'm sure she will tell you all about. However, from our side, it was weeks on end of desperate efforts to help her leave the country. We had various ambassadors engaged, vehicles sitting ready to pick Donya and her family up if they could just cross a bridge into Uzbekistan, military personnel ready to track their progress by intercepting mobile phone signals, and even a fake conference in the planning in Pakistan to which we were going to invite her to speak. In the end, Donya survived an incredible ordeal before finally escaping to Albania. This was an incredible feat of survival and determination against all the odds. However, having got to know Donya a little, it is no surprise to me that the girl who was educated in hiding and who grew up to be a surgeon immediately turned her thoughts back to the people and the land she had left behind. And so, since then, Donya has worked as an expert consultant for GICS Operating Room, advising us how we might possibly now find a way back into Afghanistan to provide surgery for those children still there. Dunya, it is clear, won't rest until every child, no matter where they are born, can access the care they deserve. I am immensely proud to work with Dunya on devising a plan for how we might reach even the most unreachable child in the most challenging environment, something she is determined to achieve. And Dunya's determination is something that no barrier has so far been able to stop. So I fully expect this will be achieved, and probably sooner than we might imagine. I am therefore looking forward a great deal to hearing her speak, and I am immensely proud to be able to introduce her to you today. Dunya, for all you have achieved and all you will achieve, thank you. You are truly inspirational.
Hello and good morning, everyone. Lack of reliable literature for developing countries like Afghanistan. My name is Dunya Mughal. I am one of the 4 female pediatric surgeons that Afghanistan had in the last 20 years. Unfortunately, I had to leave Afghanistan due to Taliban takeover on 14th August 2021. Currently, I am living in Albania and working with Kids OR for their possible projects in Afghanistan. As we all know, research is a form of disciplined inquiry that involves studying something in a planned manner and reporting, so that other inquiries can potentially replicate the process if they choose. The purpose of literature review includes to attain a good knowledge of the field of inquiry, facts, and scholars, to identify methodologies common to the field, to confirm that proposed research is really needed, helps to narrow a problem, generate a hypothesis or question for further studies, to commence a long-term study of interest. It's an account of what is already known about a particular phenomenon. The main purpose of literature review is to convey to the reader about the work already done, the knowledge and ideas that have been already established on a particular topic of research. The main sources of literature search includes electronic databases, books, journals, conference papers, theses, encyclopedia and dictionary, research topics, and magazines and newspapers. Afghanistan has been a war-torn country, so not a single area in the country is available which has not been affected by war. After 2021, research has been introduced to the medical field, but unfortunately, it's still a new concept. Lack of interest and collaboration is present. Most seniors are expecting to get authorship rights without significant contribution to the study. Plagiarism is unknowingly common culture as copy-paste. Most articles available in database are the studies which has been done by foreigner advisors who were present during 2001 to 2010 in Afghanistan. In these studies, very general topics have been discussed, and similar topics have been researched for years. For example, malnutrition, mother and child death, and mental health. These are generally the topics which gets most of the research funds, and many articles have been published regarding. When one finds the recent literature, it's mostly governmental reports. These reports are explanation of projects, and few are written in the manner to show the success of projects. So one cannot decide whether it's a reality on the ground or not. In this part, I want to have a glimpse of pediatric surgery in Afghanistan. Nearly half of the population is under the age of 15 in Afghanistan. Maternal and newborn mortality rates in Afghanistan are the highest in the world. Children are mine victims because of the war, victims of car accidents, victims of playtime at home, and even victims of attacks. The capital, Kabul, is the only place where children with congenital deformities and impairments can get competent and expert surgical care. 3 governmental and 2 private pediatric centers are in Kabul, Afghanistan. No any specialized center for pediatric surgery in 33 other provinces is available. These surgical centers include Indira Gandhi Hospital, Ataturk Hospital, Maiwan Teaching Hospital, the Edna Salimi Children's Hospital, and French Medical Institute for Mother and Children. General pediatric surgery includes all head and neck surgeries, neurosurgery and spine surgery, chest surgery, abdomen surgery, pelvic content surgery, genital and neurological surgery, trauma, and surgical disease of newborn. There were 135 general pediatric surgeons as of 2019, including 4 female pediatric surgeons in Afghanistan. There are just finger count number of publications present regarding pediatric surgery in Afghanistan. Research in pediatric surgery in Afghanistan needs work and is a fresh topic to the world. I hope that research culture gets a common culture in Afghanistan. Publication gets facilitated from developing countries, especially Afghanistan. Specific and interventional research studies get encouraged. Financial supports and research funding get available easily for developing countries. Every Afghan, including me, wishes peace for Afghanistan. We really need peace after 40 years of war. I wish no child gets sick. When one gets sick, may he or she receives the treatment that's deserved. I dream of the day when every child everywhere can be promised a cure. Thank you for your attention.
Hi, everybody. This is Erin Stieber, the Chief Programs Officer at Smile Train, and I am really honored to be able to have a few minutes to present about Smile Train's current priority areas and think a little bit about how we can all continue to work more together for our shared goals. So with that said, let me jump to the next slide. Our key priorities remain largely unchanged. The safety of every patient that we treat remains our absolute top priority. Obviously, the quality of the outcome is synonymous with that. So making sure that the patients are at the center of our treatment and ensuring safety and quality of outcomes just obviously remains our top priority. Sustainability is a key priority for us. It has been since we were founded 23 years ago, but I'm continuing to really make sure that the systems on the ground are empowered in a sustainable way to provide this care is key. And then the comprehensiveness of care, which I'll talk about a little bit more in this presentation. So capacity building is obviously a massive priority for us, as I know it is for many of you as well. And we do that like we do many things through a really thoughtful partnership model. So you can see on the left here, this is certainly not an exhaustive list, but an example of a number of the groups that we are partnering with to really make sure that education and training is available. Obviously for surgeons, for anesthetists, pediatric anesthetists, nurses, and all of the health and parahealth professionals that play a key role in ensuring safe and high quality surgery for children and for cleft patients in particular. So I know some of our GICS partners are on this list, and we look forward to continuing to grow this list. We've been making millions of dollars of investments in this space, in fellowships, in the development of capacity building training programs across a variety of specialties, and conference support. You can see at the top here, this is a 3D virtual model for Simulaire, which Smile Train now runs. So we're really passionate about continuing to grow and invest in this area, and we are eager to continue to work with others who share the same goals. The next slide is really essential, obviously, as well. As we build that capacity in education and training, it's essential that the infrastructure be available within the health systems to support safe surgery. So that's another key area where we are making significant investments around the world. You can see just a few examples of that. A cleft center we're building in Ghana, phenomenal team we're supporting in India at the top there, in Mexico at the bottom with the ribbon cutting. To the right is a picture of a joint project we're doing with Kids OR. It's an area we're excited to continue to grow and roll out to more health centers. So this is really something we're passionate about. It's making sure that the systems, the buildings, the equipment, everything is available so that care can be as safe and high quality and timely as possible. The next slide, for cleft in particular, but for many pediatric surgical conditions, a continuum of care is really essential. And here we're looking at, obviously you can see in the blue, a number of different surgical procedures that may be needed depending on the type and the severity of the cleft, but then there are massive other types of healthcare services that are needed to really ensure that a child can safely receive surgery. Looking at nutrition, obviously, in early life, it's essential to their having a safe surgery and postoperative healing, but then things like speech therapy, orthodontic care, psychosocial support. There are many other ancillary or comprehensive services that need to accompany the surgery for a child to truly be rehabilitated and have the best chance at leading a full and healthy and productive life. So these are key priorities for all of us at Smile Train and our partners around the world as well. And then I wanted to just briefly chat about research. This is a huge area of focus for us and one that's really been growing. And again, our goal is through partnership and through investments and financial support to really build the capacity of our partners around the world to conduct research, to publish research, and to really be able to do the most that they possibly can in this space. So there's a lot of really phenomenal work going on here right now. You can see that our Smile Train Express medical database has more than 1.5 million comprehensive cleft treatment records that we're also obviously conducting research on with our partners. And it's an area where we're really excited to grow. This image right here is a picture of our current STRIAC. That's our Smile Train Research and Innovation Advisory Council, which includes a number of partners from around the world, including some that are affiliated with GICS. So that is an area where we really are really grateful for the leadership that we're seeing and are able to make investments in our partnerships around the world. So I'll end there. I think all of these areas are really places where we expect to continue to grow, to expect to make more investments and hopefully work with more partners. So really eager to engage with all of you more, hopefully in person before too long. But I look forward to hearing from any of you if you think there are ways we can work together on these or other areas. Thanks so much.
Hello, everybody. My name is Ruben Ayala. I'm the current Chief Medical Officer for Operation Smile. I'm originally from Panama, currently live in the United States, and I've had the privilege of serving with this organization either as a volunteer or a staff member for the last 30 years. And it really is a pleasure to be with you today to talk about the next decade of love and leadership through health at Operation Smile. My first memory of Operation Smile dates back to 1992 when a group of international volunteers came to my hometown of David to take care of children with cleft conditions. And I was pleased to see that the moment of greatest pride for me was 5 years later when Operation Smile Panama was carrying out the work with an entire Panamanian team. We realized that delivery of health through a local foundation that supported clinicians was a model to allow for growth of opportunities that weren't there before. We're currently serving in about 40 countries, and over the years, we have been very proud to see care delivery being offered to hundreds of thousands of patients via the generosity of thousands of highly skilled volunteers, offering programs in around 60 countries, in hundreds of hospitals, dozens of centers. And we're very proud to have seen the evolution and the growth of the engagement of volunteers and our local foundations and partners in local foundations, which up to a couple of years ago was about 80% the makeup of either our short-term programs or our ongoing programs. And really lately, last 2 years, 100% the local ownership and participation. We know the challenges are great. By all calculations, some of us believe that every 3 minutes a child is born with a cleft condition. And yet, in achieving what's required for children, there's, in addition to surgery, so much that has to be done. And the challenges that have to be overcome do include everything you already know, whether it is lack of equipment, lack of supplies, not enough providers, not enough resources and opportunities for growth for our providers, infrastructure challenges, et cetera, et cetera. For us, as we serve in the different communities around the world, over the years, we started to understand more and more that it wasn't only that we needed to take care of a child with a cleft condition, but it was that the children were a bit of a symptom of the lack of access and availability of care. So in the next decades, we've set ourselves a goal of offering care to over 1 million patients. And many people want to say, well, the number, do you really want to put a number? Is this the magnitude? Do you want to go bigger? But we just put it as a target. But most importantly, we believe that by getting a target and really pushing ourselves towards that goal and putting a time allocation towards the goal, we can coalesce the efforts of people around the world truly and different members of society to do what they can to achieve such purpose. Our pillars include cleft surgery and comprehensive care, and taking advantage of every opportunity that taking care of children gives us to engage and support the health systems that offer assistance to the entire community. And certainly research and innovations that are required to advance delivery, advance access, and give added opportunities for growth of every health system we interact with. Our formula includes surgical programs and comprehensive care, and their growth and delivery through education exchanges, improvements in infrastructure, supplies, equipment, and research and innovation. We have seen that this formula works. These are some of the people and faces of our colleagues and patients in Ciudad Bonanza, Nicaragua, one of the poorest areas of the Americas. And our work with different partners has already given us over 4 years and modest investments some really important dividends in terms of increasing access to safe surgical care and also access to pediatric surgical services. So we're committed to utilizing this formula and thriving through the hubs and spokes in different countries and making the commitment and investment in resources that are required to achieve some of these gains. Countries like Rwanda with endless opportunities, Colombia, and many others as an example. I would like to close by acknowledging the power of women in medicine, and this is another area that Operation Smile will continue to invest over the next years. This is just in case you have a few extra minutes to learn a little bit more or hear a little bit more. My contact information is there. I'm willing and able to discuss with you offline and will be thrilled to engage in a dialogue. Once again, thank you for the opportunity. Children take us back to the community. They give us an awareness that is critical to understand and give us a chance to help their entire communities. Thank you, GICS. We look forward to working with so many of you around the world.
Hi, everybody. It's Chris Torgerson, CEO of Lifebox. Here today. I'm very grateful to be among friends and colleagues around the world attending this GICS webinar, and grateful to have this opportunity to give you a little overview of Lifebox and an update of our work. As many of you know, LifeBox is a global charity. We work on improving the safety of surgery and anesthesia around the world. We focus on the entire end-to-end surgical patient journey, working through partnerships, training, and tools to help focus on 3 key areas of work: anesthesia safety, surgical teamwork, and infection reduction. Right now, we're in the first year of our newest strategic plan, where we're really trying to focus on that patient journey and improve the quality and impact of the programs that we've developed over the last couple of years. And really critical to this strategic plan is a multi-year partnership that we've developed with Smile Train to really elevate the quality and safety of cleft and pediatric surgery in more than 70 countries. And this program is wide-ranging and has multiple components, of which I'll mention a few today. Our core pillar of work remains focused on improving anesthesia safety by distributing a low-cost, robust pulse oximeter and the training along with it for anesthesia providers. Together with Smile Train, WFSA, and many others, we're also helping to scope out a new low-cost, high-quality capnography solution. Here's the pulse oximeter. We've now distributed up to over 35,000 pulse oximeters, many of them with help from colleagues on this call today. The second pillar of our work is about improving teamwork. This is really the core of what LifeBox does, based in the WHO surgical safety checklist, which LifeBox was born out of. We have a number of interventions and strategies, including a checklist implementation strategy and a Safe OR workshop with many other partners to help improve surgical teamwork. And we're now, with Smile Train, also investing in improving nursing leadership around teamwork. The third pillar of our work is been focused on decreasing surgical infection. And the cornerstone of this work is a program called Clean Cut, which we piloted in Ethiopia and now have expanded to Liberia and Madagascar, which has been shown to reduce the incidence of post-operative infections by over 35% and really having wonderful outcomes and sustainable ones. And just a few highlights, since the time is limited, of some current work. Obviously, during COVID and continuing, we wanted to first and foremost work with our partner Smile Train and WFSA to help ensure that we could support our colleagues, many of you here on the call, to provide the best possible surgical care during the pandemic. And so developed a COVID-19 surgical patient checklist and did trainings on that and interventions on that. This program was also done in French in multiple language. Here's one of our colleagues presenting in French to her teams in Madagascar. Another important new element of LifeBox's work is implementing Clean Cut in Liberia and working with Mercy Ships and others to improve surgical care, including pediatric care in Liberia. And I wanted to just flag before I close today a tool that all of you, I hope, will tap into, which is the LifeBox Learning Network, is where we're putting all of our training materials and self-guided courses online and made available to clinical providers and surgical team members around the world. And hope you'll check this out. Go to our website, lifebox.org, and you'll be able to find the link for it. So thank you all very much for this quick rapid fire update on LifeBox. And I look forward to listening to others and speaking with you all soon. Thank you.
Good morning, everyone. My name is Jim Johnston. I'm the co-director, along with Marilyn Butler, of InterSurgeon, and I want to thank the organizing committee of GICS for inviting me to give a short talk today about InterSurgeon for those of you who are not familiar with it. As we all know, global surgery is a social network. Mr. William Harkness, who is a pediatric neurosurgeon and good friend of mine, passed away this past year, played a very important role in the conception and establishment of Intersurgeon. And what he and I talked about, and many of you who I've spoken with over the years, is that we live in a large network of people all involved in global surgery, from surgeons to nurses to anesthesiologists, obstetrics, trauma specialists, equipment sharers, et cetera. And we're all trying to do the same thing, but we've had a hard time finding each other in a more convenient and established way. And so what we decided to do was to put these thoughts down, to conceive of a standalone application that would be outside of any particular organization or subspecialty or country or language, that would be built on a decentralized social network architecture, much like Facebook or Uber or Yelp or Tinder, where people can come and create their own profiles with what they're interested in, what their specialties are, what their skill sets are, what they want to learn, what they want to teach, what kind of equipment they might want to share, what they want to do research on, et cetera, and then create a platform where an algorithm can be built that will automatically match people with each other they wouldn't otherwise be able to meet, so that they can participate and collaborate in long-standing, long-term collaborations, and whether it's clinical assistance or education, equipment, training exchanges, or research collaboration. I urge you to go and check out the site if you haven't already seen it. It's a really nicely done site that was put together by a professional group out of the UK that is built and to function much like all the other things we use in our daily life to find each other. There's a map function to it where you can browse, you can search by different criteria. And as you can see, there are now representatives from multiple surgical subspecialties from all around the world that are currently members. The principle of Intersurgeon has always been and will always be that this is a free service to all subscribers, both individuals and nonprofit organizations. There's no commercial advertising. Members can create a profile, offers requests, their identity is validated, and then a matching algorithm or will connect people, or you can use the map or search on your own to try and find and see what people are doing in a particular country or in a particular subspecialty you might be interested in working in. Of note, all members get free Help Lightning augmented reality software, which can be very useful for virtual mentoring. Our institution has been using it for years with our collaborators in Vietnam and Ghana. And currently there are over 800 members from 107 countries, including 45 nonprofits in all surgical subspecialties, anesthesia and obstetrics. We have a large board of subspecialty champions. You'll see Marilyn Butler prominently featured there, as well as some of you may be on the call today, who are all playing a very important role in sort of getting the word out about Intersurgeon and recruiting within their specific parts of the world and subspecialties. We're really looking to expand this to include champions from all over the world, from every continent, every country, frankly, to try and get the word out and really maximize the effectiveness of this network. We are fortunate to have many global surgical partners from the level of the United Nations to G4 Alliance, which has been a very important partner. And we're working very closely with them to get all of their member organizations on board with Intersurgeon so that we can provide resources for their nonprofit organizations and individual surgeons and other healthcare practitioners to find each other and better collaborate. Like I mentioned before, all members of Intersurgeon get free Help Lightning enterprise level augmented reality software. This can be used for, we use it for laparoscopy or endoscopy procedures for neurosurgery, as well as for craniofacial mentoring and hydrocephalus mentoring in Vietnam and Ghana. And there are many countries now currently participating with Ohana One, which you're going to hear more about today, doing some really cool work using a hands-free solution with smart glasses. So again, I really urge you to check out the site. I'm happy to answer any questions you may have. Please take the time to not only join, but make an offer and request, and contact me if you have any questions or concerns. Thank you.
Good morning, everyone. My name is Pedro Santos. I am a plastic surgeon in Mozambique, and I bring to you the experience of Ohana One, an American NGO, with the use of smart glasses for remote surgical training in resource-constrained settings. Since 2015, Dr. David Culber and a team of volunteers would come over to Mozambique annually for mission trips. It was verified during these missions that we would be reverting back to old techniques because there was no continued teaching. One of the volunteers formulated the idea of the use of smart glasses to train surgeons remotely. The proof of concept was done in 2017, and Ohana One was created in 2019 to introduce this teaching model to more countries. Currently, 95 surgeons from different countries participate in the Ohana One surgical site program. We are dedicated to the idea that everyone deserves access to the very best surgical care. We are using technology to bring the gap between skilled surgeons and the people who need them, and this will change millions of lives. What sets Ohana One apart is that we bring year-round mentorship versus the recurrent mission trip model. We are using innovative technology with smart glasses and a mentorship software platform. It is cost-effective when one compares the cost of mission trips with the Ohana One model. It has a ripple effect as mentees will become mentors. We can serve a higher volume of patients, and so far it has shown to be sustainable. The proof of concept was done in 2017. We operated on 12 patients over a period of 6 months with two sessions every month. We would use the platform to prepare for patients before surgery, but also to prepare or better prepared for the mission. The smart glasses and the software was also used for real-time visualization in surgery and also for the post-operative follow-up. We would be screening patients remotely. I would be in Mozambique and Dr. Culber would be in the United States, working together to prepare for the surgeries. Then we would move on to do the surgeries on a preset date and time. And after the surgery, the follow-up was also done. We found some limitations. The time zone is a factor that has to be taken into account. Having a reliable access to the internet is very important. At the time of the proof of concept, we had some problems with the glare from the OR lights, but this was overcome. The Ohana One Smart Glasses surgical training program is based or set on 6 pillars. We are using augmented reality smart glasses paired with a smartphone app that allows for remote surgical training that happens throughout the year. And this is done with the mentor and the mentee with an assessment that is done by the mentor of the mentee's skill. And over time, we are able to progressively train the mentee to increase his skills or her skills. This is self-directed, as the mentee will select the cases and prepare for them together with the mentor. and over time, the mentee will become more skilled. This is our application or smartphone application. As for my case, we started with simpler cases and we have over time progressed to more complex case, as in this one where we are reconstructing a ruptured tendon from an accident. Our impact: we are currently working with 95 surgeons from 6 different surgical specialties in 41 countries, and so far 1,228 calls have been logged. On an individual level, the mentee will perform and master more complicated procedures over time. The mentee will become a mentor. For the community, the mentee is able to operate year-round, thus minimizing the backlog of patients. With the help of expert surgical knowledge that would be otherwise not available in the region. With this, we bring the potential reduction in surgical brain drain in different countries. Our next steps are to recruit more surgeons to become mentors and also to acquire more funding. We are currently working with all of these organizations, and we thank you and thank them all for the help.
Hello everyone. Last time I spoke at this conference, it was in Johannesburg in 2020. Then I was VP of Global Programs at March of Dimes. So much has changed since then in our world. I left March of Dimes in 2021 and I am now working as an independent consultant with the World Health Organization. But please note that today I am not speaking on behalf of WHO here, but rather as a friend of Global Initiative for Children's Surgery. My work over the last decade has involved advocating for birth defect surveillance, prevention, and care. So in the next 5 minutes or so of this presentation, I would like to share information about some recent activities related to birth defects that may be of interest to you. First, new child mortality estimates by the UN Interagency Group were published in late 2021, followed by an article in Lancet Global Health in 2022. Once again, these data show that the rates are the highest in low and middle income countries, particularly in sub-Saharan Africa and parts of Asia. Country-specific and indicator-specific data are available on childmortality.org. Another new publication that focused on the causes of under 5 mortality with implications for sustainable development goals recently came out in the Lancet Child and Adolescent Health Journal. The graph here shows global causes of under 5 mortality in 2019. Deaths of neonates are on the right-hand side, and the deaths of children from 1 month to 5 years are on the left side. Globally, birth defects caused about 8% of under 5 deaths. So what do these reports tell us? Let's review the findings of these reports in the light of the SDG targets. The UN SDG target number 3.2 is of relevance here. The aim is to achieve an under 5 mortality rate of 25 per 1,000 live births and a neonatal mortality rate of 12 per 1,000 live births by 2030. The world has a long way to go. In 2019, the under 5 mortality rate was almost 38, and the neonatal mortality rate was 17.5. Based on these estimates, a large number of countries are predicted to not meet these targets by 2030. Furthermore, the setbacks caused by the COVID-19 pandemic are not fully known. The good news is that the World Health Organization's department that is responsible for maternal, newborn, and child health is committed to continue to work in support of the global birth defects agenda. Some of WHO's planned activities are mentioned on this slide. One of them, of note, is an effort to update the estimates on prevalence of birth defects, which have not been done since the 2006 March of Dimes report. Other activities include surveillance training and also focusing on finding out the best practices in care. Although I'm no longer at March of Dimes, some of my colleagues and friends have been asking about the next international conference on birth defects and disabilities in the developing world. You know that I organized the last one in February of 2020 in Sri Lanka. I have been told by those involved in the planning of the next ICBD to expect it to happen in Chile in March of 2023. I think at some point we'll all be able to get more information about this conference from icbd.marchofdimes.org. Lastly, one quick reminder, March 3rd is World Birth Defects Day. Colleagues from GICS have been very active supporters of this day. Please visit www.worldbirthdefectsday.org to get more information about the plans for this year and join the social media efforts if you can. Thank you so much for your time and attention.
Good afternoon, good evening. My name's Ros Owen. I'm Executive Director and co-founder of the Global Clubfoot Initiative. Global Clubfoot Initiative, or GCI, is a network of more than 35 NGOs working together to support the treatment of children born with clubfoot around the world. In 2022, more than 90% of all children born with clubfoot are born in lower income countries, where access to treatment can be very challenging. We want to change that by working together, and our vision is of a world where all children born with clubfoot can run free from disability. Us and our members are working towards a strategy called Run Free 2030, which describes how we might be able to address this situation so that all children can get the treatment we need. But what I want to tell you about today is our own strategy for us at Global Clubfoot Initiative. As an umbrella organization, we have a really unique role in bringing people together to work towards our shared vision and mission. So what we know about clubfoot in 2022 is that we estimate that around 1 in 5 children born with clubfoot in lower income countries get the treatment they need. Now, this is a really terrible situation because the treatment is actually very low resources. It's minimally invasive and it can be done successfully almost anywhere in the world, as many of our members working in some of the most challenging environments globally have shown. Clubfoot treatment comes under orthopedic surgery, and we believe that every child born with clubfoot should get access to the treatment. So our strategy falls into 3 main theme areas, which make the acronym ACT, and I'm going to tell you about them briefly now, but please do get in touch if you'd like to know more. So within our strategy, A is for advocacy, and this is an area where we're really looking to strengthen in the next few years. We're bringing together lots of different voices with the same message, and we believe that that will be really powerful in making change for children with clubfoot. We're bringing together NGOs, clinical groups and clinicians, governments, children born with clubfoot and their families, and adults living with clubfoot as well. We believe that by bringing people together, we can speak louder to those with decision-making power who should be including clubfoot in their plans and providing what is needed for treatment. We've also learned a huge amount over the last 10 years of implementation, and we believe that we have many positive case studies and stories to share of how implementation for one condition, clubfoot, can make a difference within health systems for children with other conditions too. Then C is for collaboration. And we believe that we are much more effective and efficient when we work together. Through our network, we encourage sharing of ideas, knowledge, skills, and tools. An example of how we do that is when one of our members develops a new resource, we encourage them to make that a collaborative project with other organizations so that everyone can feed into the process, we can combine our knowledge and skills, and we can also come out with a tool or a product that can be used more widely across the network by everyone. This makes us much more efficient as a network, but I believe also more effective because it means that we are learning from each other all the time. And that means that more children can benefit. As well as sharing best practice, this makes us a platform for innovation, both new developments and bringing together new ideas, but dissemination of the things that are happening within the network. We can also face common challenges together and work out how to problem solve around those, such as we did with the COVID pandemic. We helped people to adapt, we gave them good information and helped them to share best practice and work through the problems together. Finally, training. We have a really strong training program in Global Clubfoot Initiative, and it's been a real joy to see how through that training program, knowledge, confidence, leadership, as well as treatment skills have been built up around the world. Our primary training product is actually called ACT as well. It's the Africa Clubfoot Training Program, which was developed in Africa for Africa, but since then has been rolled out across the world in almost every continent. And we're now using in higher income countries as well to generate an income which then supports our training in the lower income countries. Now that training consists of clinical modules as well as a train the trainer module. And the train the trainer has really been a game changer in terms of reducing reliance on external trainers and building up countries to be self-sufficient in meeting their own training needs. And that's had a really big impact across the network. So if you're interested in finding out more about our training program, we'd love to hear from you. So I believe that's my 5 minutes up, but I just want to give a big thank you to the organizers of this fantastic meeting for inviting us and involving us in your meeting. I think it's really important to come together. Please get in touch if you'd like to find out more. We'd love to hear from you. Thank you.
Good morning, everyone. I'm glad to be presenting the G4 Alliance today, and I am the Permanent Council Secretary, the Director, as well as the Board Secretary to the G4 Alliance. The G4 Alliance currently has 68 powerful, active member organizations, and our mission is advocating for neglected surgical patients and providing a collective voice for increased access to quality, safe, timely, affordable, emergency and essential SOTA care as part of the universal health coverage. Now, I'm going to be referring to SOTA care. That just means surgery, obstetrics, trauma, and anesthesia care. I will share some updates with you, and for this purpose, I'll just take 4 of our working groups. The G4 Alliance has improved the language in the explanatory statement for the State Foreign Operations and Related Programs 2022 Senate Appropriation Bill. And this is due to the efforts of our G4 Alliance US Government Resource Mobilization Working Group, led by Mobile Surgery International and others. And number 2, the United Nations Human Rights Council adopted a resolution in July 2021 with a language that is specific to SOTA care. And our working group, the UNG4 Advocacy Working Group, continues to work to make sure that we use all the opportunities available to ensure that the resolutions include SOTA care. The G4 Alliance was represented at the World Health Organization Executive Board 150th session, January this year, and a statement was released. This statement was a result of a collaboration of 4 members: the World Federation of Neurosurgical Societies, the International Federation of Surgical Colleges, the World Federation of Societies of Anesthesiologists, and the International Federation for Obstetrics and Gynecology. And number 4, our International Standards and Guidelines for Quality, Safe Surgery and Anesthesia Working Group, that's a mouthful, released the best practice recommendation for quality, safe surgery and anesthesia. And this serves as a practical guide for all stakeholders in the global stage to use for planning and allocation of resources, as well as evaluation of our work in low and middle, low resource environments. We head into Geneva in May this year for a face-to-face meeting, and that will be the 11th G4 Alliance Permanent Council meeting. We're targeting the World Health Assembly, which will take place just after we meet in Geneva. It's going to be a beautiful, amazing meeting, and we have a lineup of very interesting events and amazing speakers for the upcoming G4 Alliance meeting. And the G4 Alliance, the Alliance for Surgical Obstetrics, Trauma and Anesthesia Care, has a mission to advocate for the neglected surgical patients. And those who want to join us, let's increase our voice collectively for increased access to quality, safe, timely, affordable, emergency and essential surgical obstetrics, trauma and anesthesia care as part of the universal health coverage. We would love you to get in touch with us. Check our website, get connected to us, and let's make the world a better place. Thank you.
Hello and good afternoon, dear colleagues and interested people in pediatric surgery. My name is Britta Schwarzmann. I'm a pediatric surgeon from Israel, and I wanted to tell you about what happened to the mobile clinic in pediatric surgery in Ghana during the last 2 years. Now, you remember, we were affiliated, or we are affiliated ourselves to a missionary hospital, and built and trained a local team. And our team, our local team and us, we've seen since 2007 until now around 40,000 patients. Now we are thriving and actually expanding. Let's see. Well, in the beginning of COVID-19, our community belief in the health system actually got shattered. After 3 weeks of heavy lockdown, but the team returned with the equipment, as you can see in the slide, to their 10 health posts. And actually, afterwards, we saw that 2020 marked an incredible increase of 30% of patient numbers in our mobile clinic settings. And if you compare it to the hospital, well, the hospitals had just reducing numbers in 2020. Here our team was Alberta, the psychiatric nurse, the Ebenezer, he is our coordinator, with Collins and Rashida as helpers, are in the orphanage of Mother Teresa and working there. Now, in September last year, we also opened the second mobile clinic in pediatric surgery in a different missionary hospital, in a different district, St. Peter's Missionary Hospital. Here you can see on the left side our first photo with the team, and of course the chief of the village, and on the other side the opening in Adowa, in one of the health posts with a lot of people coming and searching for our help. In 1 month later, in October, our first article was published about the specialist pediatric surgical mobile clinic in rural Ghana. And we were very proud to have these impressive numbers. Now we are full of new ideas and energy and new plans for 2022, and we have on our schedule already some things. The first thing is that we will have our first digital pediatric surgery conference for health staff from missionary hospitals and remote settings from all over Ghana in autumn this year. We will inaugurate our third mobile clinic in pediatric surgery with the Hope Exchange Missionary Hospital, and also there we will train teams. We will establish 10 to 12 health posts around this missionary hospital and send out the local teams to help and see kids for pediatric surgery operations. Last but not least, there will also be training for 117 nurse anesthetists in anesthesia from all over Ghana, and this will be performed in our missionary hospital in 2022. Who guided and who started with this is actually Mr. Ampofo. He is a nurse anesthetist in one of the missionary hospitals, and he, together with me, we saw the overwhelming need of training, of continuous medical education for anesthetists in remote settings. So this will take place for all these people also in this year. Yes, and Richard Stewart came with us on board. And he's helping us in our plan to establish 3 to 4 more mobile clinics in pediatric surgery in different districts and regions in Ghana. And this is all right now from us, from here. Why?
Good morning, and thank you for the opportunity to tell you a little bit about Operation Childlife and what we do. We're a global healthcare charity based and registered in Ireland. We provide specialist paediatric teams to work in Vietnam and Tanzania, and hopefully this year also Mongolia and Jordan. We facilitate international training exchanges from Vietnam to Dublin and Bahrain for doctors, nurses, perfusionists, cardiologists, cardiac surgeons, etc. And we provide distance consultations. We started as a group of nurses and doctors who just wanted to give back. We accepted an invitation from Christina Noble to go to Vietnam in 2004 and to go to Tanzania from Dr. Trish Scanlon in 2007. Our mission is to provide nursing, medical and surgical care to children in low and middle income countries, to train local teams in all aspects of the care of a sick child, to encourage altruism at undergraduate and postgraduate levels. Our vision is that all children deserve compassionate and expert health care, and that this care should be delivered in their own environment where possible. We began our operations in Vietnam, Ho Chi Minh City, Children's Hospital Number 2 in 2004, and in 2007 agreed with Hospital Number 2 to develop cardiac and oncology services. After 3 years of intensive training in Ireland and frequent visits by the cardiac team to Vietnam, we opened the cardiac program in 2010 in Ho Chi Minh City. We became a charity registered in Ireland in 2011. The oncology program began in Vietnam around 2007-2008 and around 2008 or so in Tanzania. In Tanzania, we encourage and develop surgical oncology services, orthopedics, especially for club foot, urology, and general pediatric surgery. In Vietnam, we've signed off on anorectal conditions, reconstructive surgery, anesthesia, theatre nursing practice, thoracic surgery, oncology, but are still engaged in their cardiac program, in neurosurgery and urology at City Children's Hospital, and in surgical oncology at Children's Hospital Number 2. We emphasize the importance of the principles of pediatric surgical oncology, such as the role and importance of tumor board, timing of intervention, safe anesthesia, and safe surgical techniques. And we focus on 4 main solid tumors. We encourage safe nephrectomy with minimal blood loss and no tumor rupture, and safe hepatectomy with minimal blood loss. We have demonstrated techniques for neuroblastoma surgery and preserving vessels, etc., and also very complex sacrococcygeal teratoma surgery. Is our intervention in keeping with local needs? Have we developed a sustainable program? Have we developed local capacity? Have we monitored progress and guided complexity escalation? And have we followed up, and are we aware of complications? There's always good and there's always bad. What have we done well? Well, we have set up multiple self-sustaining successful surgical programs, for example, anesthesia, cardiac, surgical oncology, anorectal, airway reconstruction, etc. We have treated in or around 1,000 complex patients in Vietnam and Tanzania. We've trained a large number of anaesthetists, surgeons, doctors, and nurses. We've established significant trust in our host countries, and we've facilitated student engagement from RCSI Bahrain on our clinical visits. We could have established more robust audit and follow-up processes. We could have funded research at an earlier stage, which would have helped that. We could have reached out to like-minded NGOs earlier. We could have instituted formal training programs. We could have directed in a better way for improved services, and we could have recruited more volunteers. We are expanding our services in Ho Chi Minh City to include ophthalmology. We're consolidating our services in both Vietnam and Tanzania. We're initiating services to Mongolia, and we're continuing to develop urology and neurosurgery at City Children's Hospital in Vietnam. We're expanding services to Jordan, which includes pediatric surgery and pediatrics, and we are developing an online consultative service better than what we have. We're actively recruiting clinical members. We're funding a 5-year Operation Child Life RCSI travel fellowship for nurses, for pediatricians, for surgeons, for anaesthetists. We're seeking to fund a full-time research fellow in Ho Chi Minh City, and we've adopted PASS, courtesy of Dr. Aiswan Holterman, as the first Operation Child Life official teaching platform. And we are participating in an online master's program in pediatric surgery in Tanzania. We're upgrading our website. We're extending our influence more widely. We've signed agreements with the Institute of Global Surgery in Dublin, RCSI, and we're establishing formal connections with Taking Pediatrics Abroad, Global Institute for Children's Surgery, and we're looking for WHO recognition. We have a strong, committed, active board. We have a team of willing and expert volunteers. We only act and visit a country when invited. We're looking to improve our funding resources. We're looking to train off-site and in a better way, and to reach agreement to receive trainees from Tanzania and Vietnam in a more efficient way. We're developing formal teaching training platforms such as PASS, and we're trying to develop better lateral agreements with other like-minded NGOs. We have a hard-working board. John Collins, Jean Hughes, Cormac Kilty are non-medics, and the rest are medics. and I extend sincere thanks to them for their hard work. But to the doctors, nurses, and allied healthcare workers in Tanzania and Vietnam, who constantly struggle for their own people, these are our guiding and brightest lights. Asante sana, kamonyo yu, shukran jazilan. Thank you.
So at the outset, I would like to thank everyone for that wonderful presentation and also for the amazing work that they are continuing to do during these tough times. So in the interest of the time, I would like to limit the questions to just a single one. So that one being from Dr. Naomi Wright to Dr. Volani. So here goes the question. How is the categorization done for causes of death in neonates or in children in the studies that were conducted by you? Sepsis and respiratory compromise and preterm birth are often related to the cause of death in patients with congenital anomalies. But how are they categorized under these studies? That is, under sepsis or under congenital anomalies? So within the literature, these amount for around 3 to 20% of the neonatal deaths. The data is almost certainly an underestimate due to lack of diagnosis, as many of the anomalies, such as congenital diaphragmatic hernia, go probably undiagnosed.
Dr. Walani, can you take the question? I'm not sure. I'm not sure she's there.
Hey, ma'am, can show me something? I don't know what the word is thing.
Well,
I want to go back to the main slides. So why is it difficult? I want to go back to the main slide now. The main person's page.
okay, so I think that I would like to thank all the presenters for their excellent presentations and very insightful and motivating work that they are doing. And I think that their excellent work is very inspiring for us. I think that, and then I will pass on to Zippy for the other session. So thank you all for participating.
Thank you so much. My name is Dr. Zipora Gadoya, Secretary of the Global Initiative for Children's Surgery, a pediatric anesthesiologist working in Nairobi. In this next session, we are going to have tributes of people who lost their lives in the wake of COVID. And we know that we are very privileged after what happened. I'm going to ask Dr. Emmanuel Ame to start us off, and or Dr. Doruk, one of them will do the presentation.
Thank you very much, Zippy. I don't know if Emmanuel's on. He had to step away for just a moment, but we had organized this session just to acknowledge the tremendous resilience and hardships that healthcare workers all around the world have faced, many of us personally, in our home lives and in our professional lives. And I think our professional lives have really involved a lot of risk and challenges, all with the same goal of our love for children and their families and doing everything we can to restore health. And it's been a very difficult 2 years. And we wanted to just spend a little bit of time in the session to acknowledge some of our colleagues who we have lost, who we cherish dearly and will remember. I think we can start the video.
Ruth, let's play the video.
I see Ruth working on it. She just has to move to the right spot.
Thank you, Ruth.
Good afternoon. I'm Dr. Beda Espineda, a senior pediatric surgeon at the Philippine Children's Medical Center. First, I'm grateful for GICS for giving us this opportunity to pay honor and tribute to our departed colleague, Dr. Leandro June Resurrection III. Dr. June, as we call him, is the immediate past president of the Philippine Society of Pediatric Surgeons and the incumbent chair of the Division of Pediatric Surgery of Philippine Children's Medical Center at the time of his demise. His passion for excellence in the field of pediatric surgery is without question. After his training in general and pediatric surgery in the Philippines, he underwent fellowship at the Royal Alexandra Children's Hospital in Australia in 2004. He started his practice in pediatric surgery with special interest in minimally invasive surgery. In 2007, he went back to Australia for a liver transplantation program at the Children's Hospital in Westmead. He was offered a faculty slot in the same institution but declined and decided to go back and practice specialty in the Philippine setting. Even while in training, he has this dream and vision of putting up a liver transplantation unit in the country because of the many neglected chronic liver diseases in children like biliary atresia who cannot afford the prohibitive cost of liver transplant even in neighboring countries like Taiwan, Singapore, and Vietnam. In fact, before the pandemic, in January 2020, Dr. June and his team members were set to fly to Taiwan to undergo further training in pediatric liver transplantation. Our institution, together with other specialty medical centers, have already finished this organizational setup for the transplantation unit duly supported by the Department of Health. Dr. June loves teaching and supervising his trainees. He was an active consultant in 3 pediatric surgery training centers in Metro Manila. His activity did not stop even during the height of the pandemic. He generously gave his knowledge, expertise, and skills. We lost him in March 2020. Dr. Leandro Resurrection is an excellent surgeon, an innovator, and a visionary. He was an avid mountain biker, a loving father, and a family man. To us, the Philippine Society of Pediatric Surgeons, Dr. June will always be remembered as a dear friend, a great colleague, and a wonderful man. Gone too soon, Dr. June, but there's an old saying that it is not in the years in life that count, but it is the life in the years that matters. Ladies and gentlemen, thank you very much.
Dr. Rahimullah Hamid of Abu Al Sinai Regional Teaching Hospital in Mazar-e Sharif, Afghanistan, died of COVID-19 on 3rd of June 2022. He was a dedicated pediatric orthopedic surgeon who was known for his passion for teaching, excellent care, and concern for his patients. He joined GICS in 2018 at the 3rd meeting in Vellore. Many of you will remember his excellent humorous speech about his work in Afghanistan. His major concern after attending the meeting was to create training opportunities for his junior colleagues through GICS and also to avail of the operation theatres for children. Hamid was the son of a carpenter, who initially trained as a nurse and worked as a cleaner to pay for his tuition. His enthusiasm was such that he impressed many doctors, and he was helped by charity to study medicine in the city of Mazar, and then went on to become an orthopedic surgeon. While he was an orthopedic trainee in Mazar, he helped very enthusiastically in a clubfoot program run by the Swedish Committee for Afghanistan and Sandy Gallup's Afghanistan appeal and made himself indispensable. He so impressed John Fixon that he became his mentor and tutored him and encouraged him to do children's surgery. Sandy Gallup's foundation sent him to Vellore to train in children's surgery, following which he returned to a government hospital in Mazar, focused on DDH surgery and its early detection, and went on to work for Red Cross and a private hospital in the same field. He did more than 2,000 DDH surgeries and presented his experience at Children's Hospital Surgery Meeting in UK, also in Germany and elsewhere. Personally, in Vellore, we remember him for his enthusiastic participation in all activities and learning, sure that he will be able to replicate what he learns when he goes back to Mazar. Afghan meals cooked by him for the department, especially his Afghan pulao, was delicious. We brought fresh Afghan dry fruits and saffron individually packed for all of us when he went home. His kindness and easy friendship with everyone and an honest desire to improve the standards in Mazar was noted. He sent several of his other colleagues to India, not just to Vellore, but also to other departments in different parts of the countries, and not just orthopedics, but other disciplines as well. His younger colleague Naveed came and trained with us in 2019. For consorting with foreigners, he was not liked very much, and he received regular death threats from the religious extremists. He once had to spend a few months in India when there were direct explicit threats which could not be traced. He learned several techniques to avoid being harmed and would vary his route from the hospital to the clinic to avoid being ambushed. His demise is a massive loss, not just for his family, his patients, but to the entire children's surgical community and for the whole country of Afghanistan. He leaves behind his wife, Dr. Munira, children Sajad, Sena, Fadwas, and Hadia. Sajad is just 14-year-old now. They are all currently in India looking to seek refugee status in UK.
Colleagues, with a heavy heart, I want to give tribute to our fallen hero, a pediatric surgeon, Dr. Sam Mutumba, who was a great personal friend, teacher, mentor, and father to many, after having worked with him for closely over 20 years as a student, young surgeon, and a colleague. He was a great teacher, and most surgeons in Uganda went through his hands. He had an art of transferring knowledge and skills to his students with ease and happiness. Dr. Mutumba was a rare doctor who looked after his patients with precision and commitment. And he did this. He always encouraged others to do the same. He taught us the art of taking thorough history and do good examination of babies in order to make a diagnosis. To him, investigations came secondary in helping with the management. This we shall always do and have been trying to pass it on to young surgeons. He would always encourage discussion of history and physical examination, even with young doctors, to come up with a provisional diagnosis. He would always tell his students that even a one-day-old baby had history. And he was doing this with a lot of wisdom, respect, and love, and everyone felt comfortable around him. He would never intimidate a student. He had incredible surgical skills and always careful and respecting tissues, and people would wonder how he was doing this, even with his big hands, despite handling small babies. Mr. Mutumba, as a father, was a very good, well-built man with a big stature, and indeed portrayed the right figure of a father. All patients looked at him as a father because he behaved like one to them, giving them a lot of time, love, and care. To the surgeons and staffs and colleagues, he was a real father. He loved us, cared about us, and provided for us. On the pediatric surgical unit, he was a Father Christmas. We have always fond memories about him. It is clear that we are very bereaved as a pediatric surgery family, but we thank God for his great life and support to us. Well done, Dr. Sam Mutumba. We shall miss you immensely. Fare thee well, my friend, Dr. Sam Mutumba.
Hello. Hello, this is Tahmina Banu from Chittagong, Bangladesh. During the COVID period, we lost one of our colleagues, Professor Ghazi Zahir Hassan. He was a professor of pediatric surgery in Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. He was very kind, soft-spoken, a true frontliner serving humanity till his last days. And he contracted COVID while he was attending patients. He died on 12 June 2020 due to COVID-19 infection in ICU. He left behind his wife and 2 sons. That's
Dear colleagues, it is with sadness and sorrow that the Sudanese pediatric surgery community had lost Professor Omar Amin last year. Professor Omar Amin was a graduate of the University of Khartoum, and he was trained and worked in Dublin, Ireland, where he received his fellowship degree. He was a professor of pediatric surgery at the University of Khartoum and the National Ribat University. Besides working as a senior consultant pediatric surgeon at Soba University Hospital, he was a founding member and an ex-president of the Sudanese Association of Pediatric Surgeons. During his term in office, the association conducted several activities, including 2 well-attended conferences. He was also a founding member and the first president of the Pediatric Surgical Specialty Council at the Sudan Medical Specialization Board, opening the door for this local degree to attract and graduate many trainees, enriching and profoundly enhancing the discipline of pediatric surgery in Sudan. He maintained his commitment to teaching and training despite his illness. Professor Omar was a passionate great surgeon, a dedicated teacher and advocate, and a magnificent tutor, supervisor, and mentor. He was keen on studying, learning, and teaching. He treated his patients with sincerity, utmost care, sympathy, and courtesy. Professor Omar enjoyed a fine sense of humor and had always brought this pleasant and joyful atmosphere to all those around him, even during his illness. Simply, he had an amazing, humble character, and he spent a remarkable life full of achievements for which he earned genuine love and respect, a life worth celebrating. May his soul rest in peace. I should also pay tribute to Professor Kamil As-Sadiq Karrar, who was one of the founding members of pediatric surgery in Sudan. He had his fellowship degree in London in 1968, and he was trained in pediatric surgery at Great Ormond Street Hospital. He was a consultant pediatric surgeon in Khartoum and in Saudi Arabia. And when he came back, he became a consultant pediatric surgeon at Omdurman Teaching Hospital, and he was a professor of pediatric surgery at Omdurman Islamic University and the Technical University. In addition to his commitment and dedication to his patients, Professor Kamil participated substantially in training of junior pediatric surgeons. He passed away in November 2021.
I would like to say a few words about my friend, William Harkness, whom I miss dearly. William trained as a pediatric neurosurgeon in Oxford and Birmingham, and he built his career at Great Ormond Street Hospital in London. Known as being technically gifted, he touched the lives of countless children while training generations of neurosurgeons in the UK. His professional accolades are plentiful and well described elsewhere. I'm here to talk about William, the person. While his vocation was healing children and his passion was teaching, his vision was a world where all children had access to surgical treatment for neurosurgical conditions. He traveled extensively to LMICs to lecture and teach, and he held numerous workshops, such as the one at the GICS meeting in Vellore on practical skills in neurosurgery. His career culminated as president of the International Society for Pediatric Neurosurgery. If you want to be both humbled and inspired, read his presidential address, where he challenges ISPN to embrace global surgery and join forces with GICS to promote pediatric neurosurgery in NSOAPs, expand the neurosurgical workforce, and collaborate with others to develop better infrastructure and create training schemes that deliver care as close as possible to the point of need. To me, William was larger than life. His lectures were meticulously prepared and delivered with flair and panache. He was gregarious and charismatic, and in his presence, one could not help but be infected by his energy and his enthusiasm and his joie de vivre. In addition, he was one of the most generous people I've ever known. In Chennai, several of us encountered Luke Malemo in the lobby of our hotel, unsure what to do because visa issues prevented him from returning to Canada on his scheduled flight. Not missing a beat, William accompanied Luke to the airport and purchased a new plane ticket for him to Montreal. Some might not know it, but William not only trained surgeons in the UK and throughout the world, but he even trained movie stars how to act as neurosurgeons. One of the many things for which I count myself grateful to William is that I can claim to be 1 degree of separation from Benedict Cumberbatch. These are the stories that come alive with laughter over glasses of wine at the bar. Despite all these accomplishments, William's greatest legacy to us is inner surgeon. And if there's one way to honor that legacy, it would be to use this QR code to go right now and register on the website, whether you are a surgeon, a nurse, an anesthetist, or a nonprofit organization. William envisioned inner surgeon to be all-inclusive and a means of connecting the world through offers from those who wish to help and requests from those who need assistance, all with the aim of promoting long-term collaborations that build capacity and strengthen systems. Snoop around the website and you will see how many tools he promoted to teach remotely with free resources such as Help Lightning and smart glasses through Ohana One, all of which could not be timelier than in a pandemic that limits in-person collaborations. In short, William lived his life with gusto and was a committed advocate of GICS from its inception. I can only hope to accomplish a fraction of his good deeds in my own life. Thank you. All right. I'm going to make a few announcements before Professor Ame ends our two-day webinar. The first thing I need to do is give a few thanks. And for that, I'm going to share my screen. And the first thing I'd like to do is to thank the moderators for the 2 days, some of whom are from our board of directors, but many of whom are LMIC trainees. Today's LMIC trainees that I need to thank are Peter Kayima and Sagar Tantanahal. The behind the scene WhatsApp conversations have been guided by Greg Klazura and Hannah Cockrell today, who have been helping to monitor the chat and feed various questions to the monitors, and very grateful to all of them. Behind the scenes, Guy Jensen again provided much of the support in organizing the trainees for our webinar. Sabina Siddiqui again made these beautiful introductory slides that you've seen throughout the 2 days. And Tina Bayu, a medical student at UCSF, has helped to review the videos and optimize their audio input so that we can all enjoy the videos that have been projected. My hero for the last 2 days is Ruth Laverde. She's been behind the scenes playing the videos and again was able to stream the various contributions that people made into beautiful videos that incorporated the introductory slides. So thank you, Ruth. You've done an amazing job. So our next session is going to be going to breakout sessions. I've listed the various breakout sessions here, and it worked very well yesterday for people to be able to select the sessions that they wanted to attend. You may find that there are more than one session you want to attend today, and all you would need to do if you want to switch between various sessions is to go to that same breakout bar at the bottom, and then it will give you the option to join the group. And so in other words, you can leave one group and join another very easily. If you have any problems with that, just put it in the chat and I'll try to help get you where you want to go. So I'm going to open the breakout sessions after Professor Ame gives his conclude remarks, and I'll stay in the main session to help people who are having difficulty. But again, so if you hover over the bar at the bottom of your screen, you'll see a button that says breakout session. Click on that and you should be able to select the session that you want. And with that, again, many thanks. I will stop sharing my screen and let Professor Ame conclude our webinar.
Thank you, Marilyn. Thank you so much, everyone, for I think these past 2 days has been very exciting. We've had very excellent discussions, and I think we have so much that we need to go back to begin to bite on, that we'll go back to begin to plan and build on what we have all achieved so far at GICS. I think at GICS, we really are making much progress towards making sure that every child everywhere in the world receives the kind of surgical care that they deserve. So we'll continue the discussions offline and by emails, and we hope that we'll continue to make our contributions the way we have been doing. Hopefully, by the time we're having our next meeting, hopefully it will be a physical meeting and we can begin to interact physically again. Hoping that COVID would have gone away by then. So thank you so much, everyone. Enjoy the remaining part of the meeting, the breakout sessions. Please just make sure that you have someone taking notes during the breakout sessions so that we have information from each breakout to use to plan what we need to do going ahead. So hopefully by the time we meet as an entire group next time, we'll probably have a new chair. So thanks so much to everyone for making this meeting a success. Thank you so much, and bye-bye.